you may press star 1 to ask a question. I would like to inform all parties that today's call is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the conference over to Mr. Lee Wilson. Thank you. You may begin.
Good morning. I'd like to open the Secretary's Advisory Committee on Infant Mortality today, June 17th, 2020. My name is Lee Wilson, and I'm the Acting Director of the Division of Healthy Start and Perinatal Services in the Maternal and Child Health Bureau at the Health Resources and Services Administration. I'm also acting as the designated federal official for this meeting in the absence of David Delacruz, and I appreciate you taking the time this morning to be here with us. Your work and advice on infant mortality and maternal health is very important to MCHB, to HRSA, and to the Department of Health and Human Services, and ultimately for the well-being of America's mothers, babies, and families. A great deal of effort and attention has gone into the planning and logistics of this meeting. Although this meeting has always been planned to be a virtual meeting, this is the first time we've done one with the entire system, soup to nuts, virtually. This is also the first time we have done one with a pandemic, with many of our staff deployed to address the public health crisis directly, including our DFO, David Delacruz, and the real churning that has arisen from months of quarantining, job losses, and economic uncertainty, and this boiling over of social frustrations on matters of race and equality and significant long-standing disparities. The work that you will be doing over these next 2 days can speak directly to those issues. We encourage you to give your full and open participation. We will be taking notes and recording the proceedings. Minutes from the meeting will be presented back to the committee to be voted on at our September meeting. We will also be allowing time during the meeting tomorrow for public comments. At this time, I have a standard set of reminders for the committee that I would like to go over. I want to remind the committee members that as a committee, we are advisory to the Secretary of Health and Human Services, not to the Congress. For anyone associated with the committee or due to your membership on the committee, if you receive inquiries about the committee, please let Dr. Ellinger and I know prior to committing to any interview. I also must remind the committee members that you must recuse yourself from participation in all particular matters likely to affect the financial interests of any organization with which you serve as an officer, director, trustee, or general partner, unless you are also an employee of the organization or unless you have received a waiver from the HHS authorizing official that you may participate. When a vote is scheduled for an activity and is proposed you have a question about a potential conflict of interest, please notify me immediately. Are there any questions? If there are, please note them for the record and we will try to address them later. At this time, I'd like to thank you again, and I'd like to turn the meeting over to Dr. Ed Ellinger. Dr. Ellinger?
Good morning, everyone, and thank you, Lee. This is a unique situation. I think most of you on this call have not seen me for a couple of years when we had our meeting in D.C. When I was there. I was not able to join you in December of this last year when I had a little medical misadventure while I was in D.C. So you can see I'm doing well, and I thank you for all of the support that you've given me, and I particularly thank Paul Jarris and Belinda Pettiford, who stepped up in the December meeting and took on the chair tasks and ran the meeting. And in reviewing the minutes, it looked like it was a great meeting. So thank Paul and Belinda. Thank all of you for the work that you've been doing, and it's nice to be back with you. Also, the last time that we had a virtual meeting, I was able to be in Rockville at the center of the action. So some of the technical things were done by people who are much more facile in the technology than I am. So that I apologize for the delay in the start of the meeting. I called in the wrong number. And so I accept responsibility for that. So thank you for the acceptance of that miscue. we've got a busy agenda, and I had some opening comments that I will share a little bit later in the agenda than right now, because I don't want to infringe upon the time of Mr. Thomas Engels, the HRSA director. And we can review the minutes a little bit later also in the agenda. We built in some flex time. So I would like to really now turn it over to Mr. Thomas Engels, who's the HRSA administrator, and really be interested in his comments. I have to let you know that I was in D.C. a couple of, last year sometime, and I got to meet with Mr. Engels in person, and it was a great conversation. He was very supportive of the work that SACIM was doing, and really supportive of the work of MCHB and all of the work related to maternal and child health. So I think we have a partner in that office. So, Mr. Engels, are you there?
I am.
Great. The floor is yours.
Thank you, sir. Thank you, Dr. Ellinger. I appreciate the fine introduction, and I wish we could have a chance to meet again. I know we will at some point in the future, but these are definitely unusual times. Thank you for inviting me here today. I want to share with you how HRSA is working tirelessly on strengthening systems to deliver critical services to our communities during this unprecedented COVID-19 pandemic. HRSA has responded quickly to organize its efforts to support the American people affected by COVID-19 while continuing to oversee more than 90 programs. HRSA works hard to support the most vulnerable populations in our country, such as pregnant women, infants, children, and families in rural areas. We at HRSA understand pregnant women and moms are fearful and uncertain during these unprecedented times, for not just themselves, but for their children and their loved ones. Responsibilities like taking their baby to the pediatrician or visiting the OBGYN to maintain a healthy pregnancy can be challenging during the best of times for vulnerable populations, but now are significantly more difficult during the COVID-19 pandemic. HRSA understands these challenges in stepping forward as a leader to provide assistance to our vulnerable populations. Let me tell you about some of the great work we've been doing here at HRSA, helping the American people during the time of crisis. The history-making responsibility given to HRSA by HHS to oversee the Provider Relief Fund is another reflection of our preeminent leadership role in addressing the unprecedented public health crisis. On April 1, HHS charged HRSA with managing a $175 billion pool of funds set up by Congress, an amount that is nearly 17 times larger than HRSA's annual budget. These federal dollars will provide relief to hospitals and other healthcare providers on the front lines of the coronavirus response. The funding will be used to reimburse healthcare-related expenses or lost revenue attributable to COVID-19 and ensure uninsured people are tested and receive treatment. Funds started flowing to providers 8 days after the time that President Trump signed in the law and will continue to do so until all the funds are expended. As part of the Provider Relief Fund, HRSA launched the COVID-19 Uninsured Portal, allowing health care providers who have conducted COVID-19 testing and or provide treatment for uninsured individuals with a COVID-19 diagnosis on or after February 4, 2020 to submit claims for reimbursement. HRSA has awarded more than $2 billion across our programs to combat the coronavirus. Since the Coronavirus AIDS Relief and Economic Security Act, known as the CARES Act, became law in late March. HRSA has awarded multiple rounds of funding to nearly every HRSA-funded health center across the nation to address COVID-19. These awards expand COVID-19 testing, build health centers' capacity to diagnose and treat the disease, and strengthen access to telehealth and distant care services for healthcare providers. To further support health centers, HRSA awarded $8 million to 73 organizations that provide training and technical assistance to HRSA-funded health centers. These organizations will provide critical COVID-19 resources to health centers, including support and expertise to advance health centers' ability to prevent, prepare, and respond to the COVID-19 pandemic. HRSA centers across the nation are playing a vital role in supporting the local community response to the COVID-19 public health emergency. Nearly 93% of HRSA-funded health centers report testing patients, with more than 73% offering walk-up or drive-up testing. Health centers are currently providing more than 143,000 weekly COVID-19 tests in their local communities, and that includes antibody testing now. HRSA Federal Office of Rural Health Policy awarded approximately $150 million to hospitals funded through the Small Rural Hospital Improvement Program. Hospitals will use these funds to provide testing and laboratory services and support the purchase of personal protective equipment to minimize COVID-19 exposure. HRSA provided $225 million to rural health clinics for COVID-19 testing. These investments will support over 4,500 rural health clinics across the country to support COVID-19 testing efforts and expand access to testing in rural communities. The funding may be used for a wide range of COVID-19 testing and related expenses, including for planning of an implementation of a COVID-19 testing program, procuring supplies to provide testing, training providers and staff on COVID-19 testing procedures, and reporting data to HHS on COVID-19 testing activities. Funds may also be used for building on or construction of temporary structures, leasing of properties, or retrofitting facilities as necessary to support COVID-19 response. HRSA also awarded $500,000 to support technical assistance efforts to rural health clinics as they expand testing capabilities. This includes activities such as conducting webinars, providing resources and guidance for implementation and management of testing programs. In addition to these rural investments, HRSA also awarded $15 million to 52 tribes, tribal organizations, urban Indian health organizations, and other health service providers to tribes across 20 states to prepare, prevent, and respond to COVID-19 in rural tribal communities. These awards were based on their needs and capacity to implement COVID-19 related activities in their rural communities and allow tribes maximum flexibility in how they respond to COVID-19 within their communities. Additionally, since April of this year, we have invested $46.5 million throughout our programs to increase telehealth capabilities in response to COVID-19. We want to help those in need to be able to access health care. We want to make it so individuals will not have to choose between health care and social distancing. When individuals can get health care through telehealth, we protect ourselves, our families, and our communities as a whole. Through increased telehealth capacity made possible by these funds, organizations will be able to maintain primary care services when clinics and medical facilities are not available to individuals for in-person services. This is especially valuable for COVID-19 positive quarantined and other vulnerable populations, including pregnant women, their children, and their families. Telehealth funding will better enable physicians, nurse practitioners, nurses, physician's assistants, and other caregivers to provide COVID-19 screening and testing, case management, outpatient care, and other essential services while protecting the health workforce and consumers alike. The HIV/AIDS Bureau awarded approximately $90 million in coronavirus assistance to 581 organizations serving clients of our Ryan White HIV/AIDS program. The awards will help grantees support critical programs that provide services for people with HIV during this pandemic, such as home-delivered meals, emergency housing, and transportation. This infusion of funds will help grantees better respond to the COVID-19 threat while maintaining the ability to provide HIV primary medical care, medications, and support services to their clients. HRSA has also improved capacity to poison control centers by making nearly $5 million in awards to poison control centers across the country to improve their ability to respond to increased calls due to the COVID-19 pandemic. HRSA-funded Poison Control Award recipients make use of these funds to increase outreach and education, to reduce the risk related to poisoning, and to enhance readiness and training to respond to and manage the increased calls related to COVID-19 related poisonings. Dr. Warren will provide more specifics about the CARES Act funding that the Maternal and Child Health Bureau received when he talks with you this afternoon. In closing, I want to thank you all for your hard work and the dedication each of you demonstrate as committee members and professionals in the maternal and child health field. You have a critical charge, and your expertise, knowledge, advice, and
Anything you want to add right now?
in the department are needed, even now more than ever. We appreciate your leadership in the field and on the committee, and look forward to working together as we develop policies and improve systems of care to decrease infant and maternal mortality in this country. Thank you all, and all the fathers on the phone, I want to wish you a happy Father's Day this weekend.
Tom, thank you very, very much. Obviously, a lot of stuff going on, and I know you have to take off for another meeting, but if we have any questions, we will get them to you through Michael or Dr. Warren. So good luck on, I can't even think 17 times your annual budget. That must be an incredible undertaking just administratively and organizationally to take advantage of that. So thank you for your work, and we'll get back in touch with you later.
Thank you, Doctor. I appreciate that.
All right. And now we're going to go as a follow-up for that. We'll ask Dr. Michael Warren to give us an update on MCHB activities and put into the sort of the maternal and child health context all of the stuff that Mr. Engel sort of teed up with his presentation. Dr. Warren, are you there?
Good morning, Dr. Ellinger and members of the advisory committee. It is great to be able to join you all this morning and to be able to follow Tom Ingalls, our HRSA administrator. We are so fortunate to have Tom's support for our activities related to maternal and child health broadly, and specifically the departmental priority around addressing maternal health and improving maternal health. I appreciate the opportunity to give you a bit of an update from the Maternal and Child Health Bureau this morning. Thank you to Dr. Ellinger and the folks who are involved in planning. This is, as you may be able to imagine, a Herculean feat to be able to pull off a virtual meeting of this size. And so we appreciate the flexibility of those who are doing that work and also for all of you in joining. Just as a reminder, Tom talked broadly about the work that HRSA is doing here in the Maternal and Child Health Bureau. Our mission is to improve the health and well-being of America's mothers, children, and families. And the work of this advisory committee certainly helps to influence that work we do, not only at the departmental level, but specifically within the Maternal and Child Health Bureau. We are working on a strategic plan for the Bureau, and I'll spend some time talking about that just a bit later and talk about some opportunities for you to weigh in on that strategic plan. But in the meantime, I wanted to share with you the framework that we're using to think about improving maternal and child health. And that framework is called Accelerate Upstream Together. And I'll tell you a little bit about what we mean by that. When the Bureau was first founded as the Children's Bureau in 1912, there were approximately 300,000 infants who died every year in this country before reaching their first birthday. And so clearly we've made dramatic improvements since then. Even in the past 30 years, we've cut infant mortality rate in half in this country, and so we celebrate that. And at the same time, folks wonder, well, what does it mean to have an infant mortality rate of 5.6 or so? Well, it translates to about 22,000 infant deaths every year. And when you try to translate that into numbers that others might understand, you say, well, that's the equivalent of a jet plane crashing once a week, every week for an entire year. And imagine for a moment if that happened in this country. After a few weeks, we would suspend air travel. We would start doing things very differently. We would call for investigations. We would say, this is not acceptable. We have to do something different. And yet, we still have this situation where 22,000 infants die every year before reaching their first birthday. And so while we've made great progress over the last 108 years in the existence of the Bureau, we have much work left to be done, and we have to accelerate that pace of change. Part of that acceleration also has to do with eliminating disparities across a variety of MCH indicators. And so if we stick with the infant mortality rate for a moment, I'm reminded of the work that was illuminated by my colleague and friend, Dr. Arthur James, who looked at the lag between black and white infant mortality rates in this country. And Dr. James has shared with some of you before that in 2017, the infant mortality rate for black infants finally became the same as white infants, but it was the same as white infants in 1980. So a 37-year lag. And so we don't think just globally about infant mortality, but we think about infant mortality for the entire population and for all subpopulations. And we think about accelerating that pace of change and accelerating the elimination of disparities. So how do we do that? I've just given you one example of infant mortality. We could have similar conversations about a variety of MCH indicators. But one way we do that is by looking upstream. We recognize that clinical care accounts for only a portion of our overall health and well-being. And I'm going to advance my slides for a second. I got behind in advancing. I got so busy talking. So clinical care only accounts for a portion of our overall health. A number of studies have pointed this out, maybe 15 to 20% of our overall health and well-being. Other factors, as shown here in these various charts from a variety of publications, contribute more broadly to our overall health and well-being. And so if we're going to think about accelerating the pace of change, we have to think about moving upstream and looking at these other factors, including community and environmental factors, health behaviors, and policy. We also have to think about upstream across the life course. And so this builds on the work of colleagues for decades who have recognized that we all have this optimal health trajectory as we age. And there are health risk factors that can dampen that trajectory, but there are also health promotion factors which can elevate that trajectory. And our ultimate outcomes are really about a balance between those health promotion and those health risk factors. But it's not just about our own life course. It's really about this multi-generational approach. And we know so well when we talk about infant mortality and maternal health about this life course approach, that the health of an infant is directly related to the health and well-being of the mother. And we can't have a healthy baby and a healthy birth outcome without having a healthy mom. Similarly, as we think about improving maternal health, we can't wait until prenatal care starts or until labor and delivery to take that focus. We have to think across the life course. And so we have to think about the health and well-being of young girls and adolescent females and young adults as we think about improving maternal health. So all of this really requires that we look upstream beyond the here and now, beyond the clinical situation that's in front of us in a hospital or in an exam room, to look broadly out into the community and to look broadly across the life course. The together part of that Accelerate Upstream Together framework really means we can't do this alone. Certainly we as the Maternal and Child Health Bureau don't do that alone within HRSA. We partner with, for example, the Bureau of Primary Health Care that works with community health centers. We partner across the government. Later you're going to hear from my colleague and friend, Dr. Wanda Barfield at CDC. They are doing tremendous work, not only at the national level, but supporting states and communities. And we are so fortunate to get to work with Dr. Barfield and colleagues and also others across the department and across other federal departments. But we also partner with states and communities, NGOs, academic partners, and importantly, families and consumers. This very meeting of the advisory committee is an example of together. We need your input, we need your wisdom to guide this work moving forward. So this Accelerate Upstream Together framework is guiding us as we move forward with development of our strategic plan. I'll come back to the strategic plan at the end of my presentation, but I did want to spend some time talking about the work that we're doing in response to the COVID-19 pandemic. And appreciate Tom giving the overview. It has been remarkable to watch the work that has been done across the federal government and across the department, and particularly here at HRSA. We know that the pandemic has had profound impacts on maternal and child health, and you see a number of those listed here. A lot of fear and worry about risk of exposure to the virus, and that results in changes in the way that people access care. Some of that is because care may not be available in traditional forms, and even where it is, folks may not be accessing care. We know, for example, Our colleagues at CDC recently published on a decline in pediatric immunizations after the declaration of the public health emergency. There are also challenges with standard approaches to care, so labor and delivery care, for example, and the ability to have support personnel, other family members, or doulas present. That has been a challenge. Similarly, challenges for systems of care for children and youth with special health care needs, and a loss of a variety of community supports. As folks have navigated this pandemic, we have seen social isolation and increased mental health challenges and needs pop up in communities, certainly increase with socioeconomic stressors and the needs that families are facing as they care for one another, and also concerns about intimate partner violence and the exacerbation of underlying health disparities that were existing before COVID but have seemed to be exacerbated as a result of the pandemic. Our concern is that these impacts that we're seeing certainly extend across the life course and may impact the MCH population for generations to come. And so we want to be responsive to those needs where we can and support states and communities in addressing those. And if we may want to ask for folks who are not speaking to mute their lines. We're getting quite a bit of feedback. So to give you an idea of what we're doing in the Bureau in terms of monitoring impact on MCH populations, soon after the emergency declaration, we stood up an incident command structure within the Maternal and Child Health Bureau to get a better sense of the various impacts across Bureau programs and across MCH populations and to help us coordinate that response. Part of that involves standing up an internal work group so that our project officers and program staff could have lines of communication with their colleagues to make sure we were being consistent in responses to grantees across the country, but also so that we could build situational awareness and gain some insight onto what the on-the-ground needs of children and families were to help guide our response. We've been deliberate in engaging partners. So, for example, we've participated now in 5 AMCHIP town halls. These are happening every other week with national representation from state Title V programs and programs that serve children and youth with special health care needs. And so through those and through a variety of other meetings, through continued contact with colleagues at CDC and the Administration on Children and Families, we've been able to find out what those needs are and how best our HRSA programs can respond. We have provided an extensive amount of technical assistance to our grantees. You'll see a screenshot there of our website where we've added COVID information with a variety of grantee flexibilities. Those have been handled based on specific program legislative authorities and requirements, but we've extended a tremendous amount of grantee flexibility during this time. We've also tried to share a variety of resources through technical assistance investments and through direct interaction with project officers and grantees to help them support their work during this pandemic. Tom mentioned a variety of the grant funds that have been made available from HRSA. We were able in the Maternal and Child Health Bureau as part of the CARES Act to award $15 million related to telehealth. And so you can see the 4 grantees there. We awarded these funds in 4 broad categories: maternal health care, state public health systems, family engagement, and pediatric care. The awardees are listed on the slides. You'll see them there in italics. I think the titles speak for themselves. I will say on the State Public Health Systems Award, that one focused on state Title V and MCH programs and specifically on newborn screening and early childhood home visiting. So those awards were made at the end of April, and the awardees are starting to implement their project plans. We also have been aware that grantees all across the country are innovating in response to the pandemic, doing things like adapting to telehealth and teleeducation platforms, piloting innovations that allow them to meet emerging population needs. And so just as a few examples, in home visiting, we've seen a rapid expansion of virtual home visiting models with support from our Rapid Response Virtual Home Visiting Project. One of the things that has come to light there, and I think speaks to the importance of understanding the needs of children and families, is that while many of our program staff and state and local health department staff were able to switch to a virtual environment to provide these services, families may not always be able to access them. They may not have devices. They may not have minutes on their cell plan. They may not have access to broadband in their communities. So this has, again, unearthed other challenges that we need to think about as we think about providing services to kids and families. Other innovations in Healthy Start, for example, they're looking at virtual client services, including virtual breastfeeding education classes. So we appreciate the innovations that our grantees are making, and we're excited to think about how we share those to other grantees across the country and thinking about scaling those various innovations. I want to wrap up my comments by talking a bit about our strategic plan in the Bureau. It has been many years since the Maternal and Child Health Bureau has had a strategic plan. And the work that we do and interface with you all on around infant mortality and maternal health is just one piece of that work. We actually have 11 different legislative authorities with multiple dozens of programs that are funded under those authorities. So it's important for us to develop that strategic plan really to serve as a North Star for the work that we do. Often we find ourselves sort of in the middle of the trees doing our work every day. And as the old saying goes, it's important to step back and to be able to see the forest from time to time. But if you think about the work we do as a national entity, we really need to take this national sort of approach. So I love this image from NASA that looks at tree canopy coverage across the country. And so as we move from the tree to be able to see the forest, we really want to be able to step back even further and look across the country at the landscape. What are the needs? What are the challenges? Where are the opportunities as we think about our strategic planning work? And really the goal is that various input from stakeholders, a variety of needs assessments, the Title V needs assessments, the McVie needs assessments, our 11 legislative authorities, priorities from the administration and the department and the agency, various surveillance data, survey data like the National Survey of Children's Health and PRAMS, program experience. All of those things would feed into the strategic plan, which ultimately will guide our budgeting, our performance measurement system, and the generation of ideas so that as new funding becomes available or new legislative authorities become available, we're able to act on those quickly. All of those things then feed into our ongoing program development and implementation work, which is of course followed by data collection and analysis. And ideally we're doing periodic self-assessments to understand how well are we doing based on the objectives that we set and the data that we collect. We know that based on that program data, and how do we feed that back into ongoing work and assessment for is our strategic plan working, and what do we need to do to make adjustments to make sure that we continue to be aligned with that strategic plan. So it's important for us to take that kind of approach. And as many of you know, when you typically think about a strategic plan, you think about a 3 to 5 year approach for an organization. So we will certainly be doing that. But we're also looking further ahead. We're taking a look down the road 15 years. So this year, 2020, Title V turns 85. It was passed in 1935 as part of the Social Security Act. So we recognize the 85th anniversary of Title V, but we also ask, what will Title V look like when it turns 100? So in 2035. So we're looking ahead to 15 years. What do we anticipate the needs of MCH populations being? What do we anticipate the need for the work of the Bureau to be? And how do we try to look ahead to address that? So right now, we are in a phase of information gathering and synthesis, which we will do through calendar year 2020. As we move toward the end of the calendar year, we'll be pulling together all that information, finalizing our plan, and disseminating some very high-level strategic objectives. And after that time, we'll move forward with further developing specific objectives for each of our MCHB divisions and offices and working on an evaluation plan. We are relying on a variety of stakeholders for input for this plan, so you will see on the upper right-hand corner an email inbox we've set up to get your input. It's mchstrategy.hrsa@hrsa.gov. These slides will be available to you, so you'll have these slides, but we would very much welcome your insights and input into the strategic plan. As I mentioned, we want to look ahead. Where will we be in 10 to 15 years? And so what can we anticipate for MCH populations in the future? Some of you have heard me say before I'm a hockey fan, and one of my favorite quotes from hockey great Wayne Gretzky, he was asked, how did he get to be such a good hockey player? And his response was, he skates to where the puck is going to be, not to where it has been. And so I think as we think about the work we do in MCH, where is the puck going to be in 10 to 15 years? What are the things we need to be planning for now in terms of the way we structure our programs, in the terms of the services that we provide to populations, in terms of the way we fund various items? what do we need to be planning for now to meet the needs of populations in 10 to 15 years? And so we set up a number of questions that we would throw out to this group as discussion starters. Again, these will be available to you, and we would encourage you to take a moment when you have time to look at these questions and to send responses to us. Again, that email is mchstrategy.hrsa@hrsa.gov, and we would welcome any and all comments that you share. We're engaging a variety of stakeholders, existing grantees, but also folks who aren't our grantees, and a variety of stakeholders in the field, and we would welcome your contributions to be added to that input. So with that, I will close. Thank you again for your time today and tomorrow as part of the advisory committee, but also for your ongoing work every day. I think, as Tom mentioned, the pandemic has really highlighted some of the vulnerabilities of the MCH population. And I think that events, even over the recent few weeks, as we are wrestling as a country with challenges of racism and discrimination and the known impacts on MCH populations, it really underscores the importance of you all being gathered and doing this work and continuing to partner with us and advise us in this way. So thank you for those efforts. We look forward to the ongoing partnership, and I look forward to being a part of the rest of the meeting. Thank you.
Thank you, Dr. Warren. I appreciate those comments. I know I've built into the agenda, because I know you have to go to another meeting, sometime right after lunch for us to have a broader conversation with all of the members about MCH issues. But would you be available for about 10 minutes to take some questions right now?
Yes, absolutely. And I do look forward to that conversation later. I have to step away for about an hour at 2:30 for another meeting, but I should be with you all the rest of the time today and tomorrow.
All right, very good. So while we're getting these questions, I have one question. You know, what the administrator said, you got $175 billion, and most of it seems to be going to the healthcare part. And given your slide saying, you know, it's more than just healthcare. It's actually, some of the other things are actually more important than healthcare. Talk to me about the conversations within MCHB and HRSA around how to balance investments at this point in time.
Thank you, Ed, for that question. So the money that you mentioned largely is coming through the Provider Relief Fund that was set up to support providers. And so certainly that does support clinical care work. I would say that many providers, though, also are thinking about how they address some of those other needs in the work that they do with patients and families and in the broader work that they do with communities. Our funding, of course, is always directed based on the legislative authority, and so there are times where we have more flexible funds. Our block grant is a great example of that, where there are some broad strokes in the legislature that tell us how that money is to be spent. But there are other times where the funding is much more prescriptive, and the funding for the Provider Relief Fund certainly would fall into that category. At the same time, I would say it is important to note my comments on clinical care were not meant to diminish clinical care at all. It's absolutely important. We can't have health without clinical care. But the point of the comments was to say it is just one piece of the approach. Certainly in talking to clinicians and in my own clinical experience, I recognize I can't fix all of the health challenges that my patients face in a 15 or 20-minute office visit. Even if I had the luxury of an hour office visit, there are broader challenges that influence their health. So it's important to continue that conversation, and I would go back to say we always have to make sure with our funds that we are spending those in the manner in which they're appropriated by the Congress.
Great. Thank you, Michael. We've got a few questions. Tara Sander Lee, unmute your mic and ask the question of Dr. Warren. Tara, can you unmute your mic?
As a reminder, if you would like to unmute your mic, please press star one. Thank you.
Tara, are you there? R1. We're going to have Belinda, you're next.
Can you hear me?
Can you hear me?
Yes.
I can hear you.
Oh,
Thanks,
sorry.
Belinda.
Okay.
Oh,
Thank
okay.
you,
Sorry.
and thank you, Michael, for that presentation. Appreciate it, and I'm really applauding the additional COVID funds that were able to go out in communities. I guess my one question is around the whole issue of equity. I mean, if we look at COVID in this country, and as you know, I work for Title V in North Carolina, and we're fortunate to also have a Healthy Start site. And, you know, I'm on the AMCHIP board, and I'm also on the National Healthy Start Association board. So I think I bring a unique perspective. I guess my question is, as the COVID funding was going out the door, it's not clear to me that we have a strong focus on going down to the community level. And I'm thinking through in my own state, and I'm hearing data from around the country, that we're seeing a greater impact with COVID in communities of color, especially African-American communities and Latinx communities. And I'm wondering, with the $15 million in telehealth and some of the other monies, were there conversations around trying to get the money down to the community level? I mean, I'm very familiar with the money that's going to UNC Chapel Hill. We partner with them on numerous things. And, again, I'm an AMCHIP board member, so definitely support that. I know the work with family engagement is typically around children and youth with special health care needs. And then you've got the Peace Society. So I'm trying to figure out in my head, how did we put any money down into communities of color? And wondering why Healthy Start wasn't considered, because it is one of the programs in your bureau where you're looking at perinatal health disparities. But I see where Healthy Start is mentioned. I don't see where the resources went there. So were there conversations around that, and are there plans to put some additional support there, and support meaning resources as well?
Yeah, thank you, Belinda, for that question. So the intent of those funds, and again, if we think about going back to the legislative intent of those funds, were around telehealth. And so the intent is actually that those funds do support the work so that patients and families in communities have better access to care. And so whether it's in the maternal health space, whether it's in the pediatric care space, whether it's relating to newborn screening or home visiting, that was the intent. And so while those awards went to a small number of entities, the intent is that those awards support work that diffuses out across the country to support telehealth access for patients and families. So that would involve work at communities, at the community level. Certainly, if we were to get additional funding, or if we were to have broader funding, we could look at other options there for how we might make use of that funding. I will say that across our existing programs, even where we've not gotten additional funding, we have looked at where we have flexibility. So how can we spend existing funds? Healthy Start is a great example on virtual services to meet the needs of families where they are. I gave the one example of virtual breastfeeding classes that one of the Healthy Start programs is doing, but folks are providing a number of services virtually, or looking at how they can use grant funds to meet other needs of families in those communities. Those are handled on a program-by-program basis, so I want to be careful that I don't say you can use funds for X, Y, or Z, because the different legislative authorities sometimes limit us into what we can do. But certainly, as programs have been reaching out to us, we've been exploring where there are opportunities to use their funds in a way that's consistent with the legislative authority, but also responsive to these unanticipated needs that have arisen as part of the COVID pandemic. I'll also say that with all of these telehealth awards, there is a thread running through those of thinking about equity and how do we use those awards to further health equity. So whether it's in maternal health or pediatric or in the public health award space, thinking about how these awards, and we're asking these grantees, how do we do this work to further this work toward equity? As you know, this $15 million is not going to be enough to get us to health equity for MCH. This is ongoing work that we'll have to look at across our portfolio, not just in these telehealth awards, but across all of our investments, and specifically across our larger investments. So the Block, McVie, and Healthy Start, I think really are our biggest levers to continue to move that equity work forward.
Tara, do you still have a question?
Yeah, sorry, I apologize. Can you hear me now?
If there are any other questions, just raise your hand.
Oh.
Michael, I have just one with with that $175 billion coming into HRSA, obviously that's puts a big stress on the infrastructure that you have in the organization. How are you, do you have enough staff, and how are you being asked to participate in all of that? How are you keeping some of these other essential programs front and center when there's a need to get out $175 billion? I imagine that this is stressing the whole organization. And how are you protecting MCH with that?
Thank you, Ed, for that question. It's a good prompt to remind me. I want to give a shout out to colleagues in the Bureau and across HRSA. It has been remarkable to watch how folks have transitioned to a virtual environment. Prior to 3 days ago, so this Monday, virtually all of the HRSA staff were working virtually. We transitioned the week of March 16th to a maximum telework environment, and that was true for many colleagues across the federal government. And I will say it felt like colleagues in the Bureau didn't miss a beat. They were responding to a massive volume of grantee inquiries, while they were also living in communities. The D.C., Maryland, Virginia area has been one of the areas that, as you all probably know, very much impacted by COVID-19. And they're navigating that with children at home or with caregiver responsibilities. And so they've really done that flawlessly. A number of them have also been deployed. And so as Lee mentioned at the beginning of the call, Captain Dela Cruz, who is our designated federal officer for this advisory committee, has actually been deployed multiple times. He's part of the United States Public Health Service Corps, the commissioned corps. And many of our MCHB staff have been deployed across the country in a variety of settings. Some of those have been to provide patient care or public health support as part of the response. Broadly within HRSA, there have actually been a number of folks pulled to be involved in distribution of this provider relief fund. Our deputy in the Bureau, Laura Kavanaugh, who many of you know, has actually been on detail since mid-April to the Office of the Administrator working on the Provider Relief Fund, one of our other senior leaders within the Bureau, and then several of our program staff. So we are stretched, and I'm happy to say folks have been doing a tremendous job. We are certainly working to try to make sure we're checking in with staff to make sure that folks feel supported and looked after. We're supporting them with a variety of flexibilities, recognizing that the stresses of working from home and having caregiver or parent responsibilities can be challenging, and so we're working to support them as we need to. But it has been a heavy lift, and colleagues across HRSA have really done a phenomenal job of getting not only those provider relief funds, but all those other supplemental grants that Tom mentioned, getting those out the door in a timely fashion.
Great. We'll take two more questions, one from Kara Sanderlee and one from Magda Peck. Kara?
Yes, hi. Michael, thank you so much for your presentation.
If you'd like to unmute your mic, please press *1.
Oh.
Kara, are you there?
Can you hear me?
*1.
Yeah. Okay, sorry. Oh. Can you hear me?
All right, let's go to Magda.
Let's do a voice check. Is it working?
Yes,
yes.
It is. Yes, it is.
Excellent. Thank you. Dr. Warren, a pleasure to see you virtually, and hearty thanks to the extraordinary above and beyond work that folks are doing on behalf of our nation's women, children, families, and fathers. I noticed that the legislative intent and the response that you have done to HRSA and specifically MCHB has been under the rubric of COVID-19. And we also know that COVID-19 has elevated, amplified, and revealed and accentuated the underlying drivers of racism. And so I'm wondering if you see opportunity to go from talking about racial disparities to speaking more directly about the impact of racism as a public health crisis, specifically to women, children, families, and fathers. And so given that these are, some have called twin pandemics, or others have called it the shadow pandemic of racism, revealed, particularly anti-Black racism. How do you see that we might be able to further double down and invest upstream as an uninvited opportunity from COVID-19?
Thank you, Dr. Peck, for that question. Absolutely agree that the impacts of racism on MCH populations are profound, and I think it's important to acknowledge, and many on this committee know well, that while there may be a relatively recent revelation and maybe increased attention to these challenges, they are not new, and populations of color have been dealing with these challenges for centuries in this country. And the impacts and the outcomes that we see in the MCH population reflect that and are reflected in those disparities. And so we have tremendous opportunity, and I think there's an opportunity now with conversations that are going on to really ask deeply of ourselves and of all our partners, what can we do and what can we do differently? I think it's important for us as the Bureau to listen, and to listen to communities, and to listen to states, and to listen to individuals about what you think we might be able to do and do differently. The timing in conjunction with our strategic plan development gives us a great opportunity to think about how do we shape that strategic plan to assure that we achieve equity across MCH populations. And so I would encourage, as folks are responding to those questions, or to provide other comments, whatever you'd like to share, to please let us know what you think the Bureau can do about equity. Certainly, as I mentioned earlier, we always are bound by the legislative authorities that we have with the programs that we have, and there is often flexibility, and some of our programs are more flexible than others. So we would absolutely welcome your ideas. We welcome hearing from you about your experiences and lessons learned. For us, lessons you have to share for us about what we can do. Our commitment is to listen and to explore how we can best respond, both with the resources and with the authorities that we have. And we are committed to do that. We've been committed to doing that, and we will remain committed to doing that moving forward.
Great.
Thank you,
Thank
Michael.
you, Dr. Warren. Thank you. And I built in time in the agenda right after lunch to have really an open conversation with you and Dr. Barfield and other ex officio members and SACIM members to really talk about what are the MCH issues we're seeing in the communities, and sort of collectively give you some input on your strategic plan and other federal agencies on what you can do. So I look forward to that conversation. So thanks for your comments this morning.
Thank you.
All right. Now I'm going to take about 10 minutes here to, if I can get my slides up here. All right. I was going to start off the meeting with some opening comments, but given my inexpertise of getting on, so we started a little late. But it will take a little time before we have our presentation related to COVID and other issues to sort of set the frame. So first of all, again, welcome, and thank you for being part of the SACIM committee. It's an important committee. I think it's increasing importance. And virtually it's really hard. I know, most of us are getting used to doing Zoom conferences and Facebook Live and those kinds of things, but 2 days of virtual meeting is going to be a challenge. And so let's hang in there together and see what we can do. When I was planning this meeting, I wasn't at the last in-person meeting, but going through the minutes and seeing what you did in terms of setting up work groups, as we started the planning, all of a sudden, out of the blue came COVID-19. And it was very obvious that this was changing our whole perspective, and it was going to take a lot of our emotional energy and a lot of our physical energy and a lot of our time to deal with COVID. So we started really looking at setting up this meeting, thinking that here in June, COVID would still be front and center in people's minds. And so started to plan this meeting around COVID-19 and its implications, particularly when we were finding out that it was really impacting the most vulnerable populations, and it was particularly having impacts on pregnant women and babies and the delivery. And it was from those conversations and those concerns that we generated the March letter that I sent to the Secretary related to how can we respond from a maternal and child health, from a pregnant women and infant perspective on how to deal with COVID, with those recommendations. And we'll be talking about those after lunch. But I thought it was interesting that as we were talking about personal protective equipment, this is a picture, an artist rendering of what actually face masks look like during the bubonic plague. And that is an accurate perception of what the face masks used in the Middle Ages. They filled in that nose with astringents to try to protect the people from bubonic plague. But as we were dealing with COVID, certainly everybody became aware just 3 weeks ago of that, as Magda said, sort of a shadow pandemic, the institutional and structural racism that's in our society, and which really was manifested and culminated in the murder of George Floyd here in my city. And this has become has become a central focus in our community, and a lot of conversations around this memorial that I took a picture of just the other day. It's the fact that it highlights the underlying reasons why COVID is having such great impact on populations of color and indigenous individuals, indigenous peoples, because of all of the structural disparities and racism that is built into many of our systems. And it struck me at the same time that this was going on. We had an exhibit at the Minneapolis Institute of Arts related to refugees, and that had to close because of COVID-19, but it pointed out the fact that this is a picture of the Minneapolis Institute of Arts, just a few blocks away from the George Floyd Memorial. And what those are life jackets that have been discarded in Turkey and in Greece, and that were collected by the artists from refugees from Afghanistan and Syria, hundreds of thousands of refugees. And the whole point of the exhibit was, when home won't let you stay. And it really struck me that this is, where we live has to be supportive, and it has to be conducive to being able to be safe and thrive. And it also reminded me that the land that I'm on right now talking to you was Dakota land. And I suspect that you can identify the people, the indigenous peoples whose land you are now on, wherever you are on this call. And so it really started me thinking about, when people are not safe. And certainly when home is not safe, when home doesn't want you, it really leads to a lot of stress. There's the new term called solastalgia, which is a combination of solace and nostalgia, which highlights the fact that when your community doesn't support you, you feel lost, you feel homesick, and it actually impacts your health. And when we know that we can't breathe in our community, when the police are disproportionately impacting some populations over others, when they're using force upon peaceful protesters, it really highlights the fact that for many people, where they live is not safe. Home is not safe. Home doesn't want you there. So it made me expand the focus of this meeting so that it was not just about COVID and its relationship to maternal and child health and disparities, but also we needed to add the fact that structural racism, institutional racism is also part of that, and we can't separate. Those are parallel or twin, as Magda said, twin pandemics or parallel pandemics or interacting pandemics that really enhance all of our things. But it also gives me some thoughts that we really do have some opportunities, because when I look back over history, pandemics have actually changed things. They, yes, caused lots of damage, but the bubonic plague actually helped eliminate feudal governance in Europe. The yellow fever plague actually led to the stopping of the slave trade. The cholera epidemic really led to some major changes related to sanitation and changed how our system works. So that pandemic is giving us some opportunities. Despite all of the struggles and all of the pain that it is causing, there are some opportunities and potentials that will come from that. So plagues can change history, and I'm hoping that that's why this time is so important for SACIM. This time is so important for all of us in the work that we do throughout the country. At the same time, I was really struck by this last week's bestseller list of the New York Times. Look at those titles. These are what people are, this is what people are reading. These are all books and the top and the bestseller list that really relate to the struggles that were going on with racial equity and racial inequity and racial justice in our society. That tells me that people are reading, are interested, are wanting to have the conversation, are primed for the kinds of activities that can bring forth some change. And we see that in protests throughout the country, and I think that this opportunity that we have now is unique, and we need to take advantage of it. And so we're looking back at, sort of how have we traditionally done things, that particularly around infant and maternal health. How have we kind of organized all of our thoughts? And these are slides that I did share back in December when I wasn't there, but, usually we have a, predictable time frame. We try to develop comprehensive strategies, and we try to get all of the data into a perfect form and get them into a complete and polished document. And then we can develop a plan. So that's traditionally how we've worked. But now I think we have to really think about the fact that time frames need to be really short. Things are changing so rapidly that we need to think more in terms of short-term opportunities. Yes, we need to plan for the Title V celebration in 15 years, 100th anniversary. But we can't wait for a plan for 15 years. Yes, we need to think long-term, but we have to act now. And the strategies that we have really are based on the opportunities that we have right now. And we need to be open-ended because the opportunities may not fit into a linear framework. And it needs to continually change. And so we need to really develop an adaptive approach, adaptive action approach, and that's what I'm hoping SACIM can do. And I think that's what we try to demonstrate when we put together our letter to the Secretary in March about how to advance changes related to COVID. And so SACIM is dealing with lots of complex issues and complex systems that are nonlinear, that there are multiple factors. All of these factors are interactive and they're constantly changing. And there's no endpoint. They're constantly redefining what's unacceptable. And they're unexpected, and rules can change, and there are multiple players. So given all of this, we're dealing with some complex things. And when you're dealing with complexity, I think we know that, at least the people who know about complex theory, know about developing simple rules. That's how do you think that the murmuration of starlings and the V shape of geese, it's because they follow some simple rules. Fly to the middle, don't bump into one another, and match each other's speed. That's what allows them to do complex things. And I think that with SACIM, I think we also need some simple rules, that if we think about everything that we do related to these rules, we will be able to work collectively, we'll be able to work collaboratively, we'll be able to move forward, and we'll be able to adapt as things change. The simple rules, and we may want to pare these down at some point, but remember, every baby and mother, center on equity, listen to community voices, build capacity, focus on connections, those partnerships, ask powerful questions, and seize opportunities. And so that's what we're doing today. We're trying to listen, we're trying to center on equity, we're trying to build capacity, we're building those connections and seize the opportunities. And I think it's a good day that we're having this meeting because this is the birthday of James Weldon Johnson, one of my heroes. He was a writer, a poet, a civil rights activist, worked with both W.E.B. Du Bois and Booker T. Washington. in a whole variety of ways. First African American, actually, to lead the NAACP. For many years, for the first 10 years, it had been led by white people. Florida Bar, first African American. He said the battle was first waged over the right of the Negro to be classed as a human being with a soul. Later, as to whether he had sufficient intellect to master even the rudiments of learning, and today it is being fought out over his social recognition. That was true 100 years ago. Sadly, it's true today, still fighting for that social recognition. And let's highlight the fact that he also wrote the words to lift every voice and sing what's considered the Negro national anthem. Lift every voice and sing till earth and heaven ring with the harmonies of liberty. Stony the road we trod, bitter the chastening rod, felt in the days when hope unborn had died. Yet with the steady beat, have not our weary feet come to the place for which our fathers sighed. We have come over a way that with tears has been watered. We have come treading our path through the blood of the slaughtered. Out from the gloomy past, till now we stand at last, where the white gleam of our bright star is cast. I think he was highlighting the fact that all of these struggles that many populations in our country have had, many populations of color and indigenous folks have struggled with. Our job is to work collectively with them, to stand with them, to work with them, to work collectively so that we can all have our bright stars shine. And so that's the frame that I want to have with our meeting today, that we follow some simple rules, that we focus on equity, that we build partnerships, that we learn from the COVID experiences and from the racial justice work that is being done, and have our work, move forward with those things in mind. So with that in mind, we've got a panel coming up that I think is really, really important for us to hear. And we've got Rahul Gupta, who is the Chief Medical and Health Officer and Senior Vice President and Interim Chief Scientific Officer of the March of Dimes. We've got Joya Creer-Perry, Founder and President of the National Birth Equity Collaborative, and Ken Harris, Senior Project Director of the National Institute for Children's Health Quality, or NICHQ. And I had seen a presentation earlier on from a couple of these individuals related to COVID, and recognized that the issues of COVID and the issues of racial injustice really merge. And so I've asked them to each take 10 minutes to talk about their perspective on that, and then we'll have a 30-minute conversation with all of the SACIM members and ex officio members about some of these issues. So I think I'll turn it over to, Dr. Creer-Perry is going to go first. All right, you have to unmute your phone. And somebody in Central kind of help us out with this.
To unmute your phone, please press *1.
Is there any other way of unmuting her?
You can also press *0.
Dr. Ellinger, she asked in the chat if you want to go to somebody else while she tries to figure out her audio. Do you want to start with somebody else? Or?
Is Dr. Gupta on board?
Yeah, he said he's happy to in the chat.
Okay, very good. Let's go to Rahul.
Can folks hear me?
Yes, very good. Good to see you, Rahul.
Thank you, Dr. Ellinger, and thank you everyone for having us today on the panel. We really appreciate both the time as well as the focus on these issues. They are critical, as Dr. Ellinger just mentioned, and they're very, very important. So I will start with that. Let me just first of all talk about both the maternal infant health and as well as COVID-19 and the equity issues. Why they're important is every pandemic, every issue we have when it impacts population within the United States, it's like peeling a layer of the onion. And when we peel that layer, very similar to COVID that we're seeing, we begin to see really the underbelly of our society. So today, we know that African Americans are likely 2.3 times more likely to die as a result of COVID as opposed to white and Asian population. That's the underbelly. The March of Dimes mission, I want to share with everyone, is the ideas of ending preventable maternal health risks and death, as well as preterm birth and infant death, with the lens on understanding that we can never achieve that goal unless we first end the health equity gap. That's a very important gap because today a black woman is 3 to 4 times more likely to die during pregnancy and childbirth as opposed to a white woman, and the risk of preterm birth is about 50% higher for a mom giving birth to a baby if she's black. Similarly, we know that infant mortality, too many babies are still, about 22,000 deaths happen, similar number of stillbirths. And there's more than twice the rate in African American population as opposed to white population. So this is a very important piece of our mission. What our organizations like ours are doing, we're certainly helping lead the work, but before that, I just want to make sure that I'm sure it's been covered before, that we have very limited pregnancy-specific data. So the second issue beyond the way we see pandemic is the way we see pregnant women treated typically. We saw some lag in H1N1 pandemic. Similarly, we're seeing, that while pregnant people are at risk as the rest of the population for contracting COVID-19, but pregnant people are at higher risk for serious complications, primarily because we have more women that are giving birth first time who are older with more complications of health. So as our aging population, we also have an aging pregnant population. As a result of that, all of those risk factors that apply do apply to pregnancy as well. We know that vertical transmission has not been demonstrated, but cases and individual case reports of babies born to moms with COVID-19 and contract the virus soon have been recorded. We also understand that postpartum, the rate is quite low for infants, whether symptomatic or asymptomatic. Limited data suggests that COVID-19 does not transmit through breast milk, and mothers are encouraged to breastfeed. We are making sure in hospitals across the nation that we have more opportunity when the environment is safe and appropriate to do so. The mothers are able to have both birthing in the presence of her loved ones, but also being able to breastfeed, because that is still the primary public health intervention to ensure a future both a mother-baby dyad, but also from a science standpoint. And really, pregnant people should continue their routine prenatal care, although certainly the shape of that has changed today. We have been fortunate to be an organization that had already some advances within technological aspects of it, so we were able to really move forward quickly. But as you can see on the right-hand side, the work we do is with a lens of health equity. During this time, we are continuing to advocate for efforts to improve data collection as well as research, especially in pregnant women. We are continuing to robustly support the requests for ensuring that CDC and others have the ability to collect real-time, close to real-time data for pregnant women. We're engaging and educating both professionals and consumers on the latest information, but also thought leadership. You might see this today. You'll see in the Washington Post, I've got an opinion editorial talking about why this could be a baby bust, as a contrary to what we think. And there are some parallel, it's interesting that Brookings economists have done a parallel assessment to the piece that I've written about, that we could see between almost 500,000 fewer births next year. Now, understand that United States, our total fertility rate is already about 1.71. We've been dropping about 2% a year. We've also had significant, which is good, drop in teen pregnancy, about 8% a year. So it is not unusual. And if you look at the history of the 1918 pandemic, if you look at the uncertainty with 40 million job losses, a ban on immigration, and if you look at the fact that most of the fertility services are stopped, there is a real serious long-term concern about the economic viability, but also the finance, as well as all of the other demographic aspects of having a tremendous drop in births. We're also virtualizing our programs. So we've had a number of programs in nation across hospitals of NICUs, like a NICU Family Support Program. We're also providing group prenatal care programs to sites across the country. And we've actually worked to virtualize some of those, knowing that it is not a time where 12 women could get together and in a room and talk. So we're doing some of that work through virtual support. We're continuing to work with both registries domestically in the country and supporting that both in legislation as well as in advocacy, but also then working with others like Lausanne University Hospital in Switzerland to encourage that underserved population and include in those registries. So for example, working with researchers there to not only include data from Western Europe and United States, but also we're helping fund some IT work that we've now been able to get access to about 3 countries in Africa that can also enroll women for pregnancy, COVID-related pregnancies. And of course, we have COVID Intervention and Support Fund, through which we're distributing things like blood pressure cuff, breast pumps, building face coverings, or creating face coverings through our volunteer engagement and distributing those, as well as other activities that are ongoing, including educational webinars. One of the important parts that Dr. Ellinger mentioned, and I would like to reiterate, is we have something called the implicit bias training. We have worked about a year and a half on this to actually create a training program that increases the awareness of implicit bias and stimulates action. This is the only training focused on maternity care providers. We believe this is the very important tool. It is not the only tool to address implicit bias in maternal health care, as well as the structural institutional racism. We're happy to share more details on request. We still have challenges. We still have challenges because we may expect, as much as I mentioned, to see further declines in fertility, but also expect to see higher preterm birth rates and higher severe maternal morbidity in the future. We do have, as I mentioned, lack of real-time data surveillance across the country, and it is really unacceptable. We have clearly inadequate testing and surveillance capacity, and as well as enrollment, making sure that there is an enrollment of pregnant lactating women in vaccine and drug trials. The inequitable burden of disease and in regards to hospitalization and deaths, as I mentioned, is one that is unacceptable, and that's why making sure that we have appropriate testing as well as ability to maintain surveillance in a real-time basis is so critical while we're addressing those social determinants that impact really the core of our societies. We're focused on research, policy, and equity. As I mentioned, it's very important for us as we move forward to have an equity lens in order to make those changes happen and be those sustainable and societal changes across the board. Things like broadband become important, and your support for broadband access, because one of the things that would happen is, again, in the spirit of exposing the underbelly of systems and structures, when we start to have virtualization and untested payment models for virtualization, which is good, but on the flip side of this, we could really exacerbate the racial inequities that already exist because of it becomes an access issue. So it's very important to make sure that every American has the same ability to have access to broadband and to the services. With that, I will turn it over and really look forward to discussion. Thank you.
Thank you, Rahul. Let's see if we can now get to Joya Perry. Let's see if we've got phone issues working. Joya, are you there?
Miss Joya, please check your mute button.
Not hearing anything. Can we go to Ken?
Can you hear me, Dr. Ellinger?
I can. I can hear you well.
All right. As soon as the presentation comes up, I can go ahead.
All right, go ahead.
All right. So thank you, Dr. Ellinger, and I also want to thank Dr. Warren for his presentation earlier and Dr. Gupta. And thank you to the members of the Secretary's Advisory Commission on Infant Mortality. It's a pleasure and a great honor to be with you all today, along with Dr. Joya Perry as well. So racism is killing Black people. It's sickening them too. This is a recent article that I read by Michelle Williams and Jeffrey Sanchez in last week's Washington Post. And the question to ask is really what led to disparities in the first place, if we want to really address them. So inequalities, and inequalities then led to these inequities. And growing up, and my father was an organizer in Memphis, Tennessee, but in our household we heard this saying, when America gets a cold, Black people get pneumonia. And when we look at disease in this country and then conditions, almost any one you pick out, you're going to see that there are disparities and Black people are doing the worst. So again, when America gets a cold, Black people get pneumonia. We also see that African Americans are disproportionately diseased and dying from coronavirus. Again, the early report in the Washington Post let us know that African Americans have 3 times the rate of infections and almost 6 times the rate of death, where white residents are the majority. And so coronavirus hits the poor and it hits minority communities harder than it hits others. And we also know, even from Dr. Gupta's presentation, it's going to impact pregnant women and impact vulnerable Black women even harder. So under these crises, Black women are struggling to survive. Many of the families that are served by Healthy Start programs, for example, live in poverty and were already on the edges of life, have fallen off. They've been disconnected from a myriad of services. They've been displaced by COVID-19 from jobs and resources that have made everyday life increasingly more difficult. They've also been distressed by the effects of social isolation from their families, from their social support communities. And now today, they're disheartened by racism. So what happens when you combine a pandemic requiring 3 months of social isolation under stay-at-home orders, an emergence of data reminding us of the gross disparities that cause Black people to bear the greatest burden of disease and death in America, and another assault of racism at the hands of, knee of, a white police officer who has no regard for human life. We knew that when COVID-19 hit America, that Black people would bear the greatest burden of disease and death. Disparities in health outcomes continue to emerge as the theme of the lives of Black Americans and people of color in this country. And as if the mental health impact of social isolation wasn't enough, Black Americans were met with the trauma of racism the very moment that they stepped out of their homes for the first time in months. It's the kind of thing that takes your breath away. While we're wearing masks and gloves to protect us from the exposure to a deadly disease, what will protect us from a disease that is alive in America in its very structure and its systems? And what was it, or is it, about George Floyd's killing that caused what some are calling a tipping point? Gaps and cracks. Gaps in services and the cracks in the system have been exacerbated during COVID-19, creating even more challenges now than before. When we think about data that's needed to combat these two pandemics is the live data that's resounding in the many voices that are screaming out for justice and equality. The data that we have in hand needs to be disaggregated by race and ethnicity to tell the stories that need to be told about the people bearing the burden of disease. Real-time data, but I want to introduce real-life data. Since that landmark report of the IOM, Unequal Treatment, evidence continues to demonstrate that even after these differences are accounted for, race and ethnicity remain significant predictors of the quality of health care received. People of color experience poor treatment based on their assignment of lesser value. What are the experience of mothers? And what is our expectation of ourselves as we serve mothers, children, and families during these times? As we look across the timeline, from the beginning of Title V, in the Children's Security Act of 1935 up till now, we've seen great innovations in maternal child care. We continue to pursue and be better. But we also have another timeline and aligned with that, and that is from 1619, when the first Africans were enslaved. And each century, we saw different things happening to communities of color and Black people in particular. But it's this timeline that has that maternal child health legacy. We see that Black women have been struggling for a long time. Even as we look at disparities in maternal mortality, where Black women are dying 3 to 4 times the rate of white women, Black women are struggling, and they have been for a long time. So as we look ahead for the next 100 years, what do we want in the next 100 years? Basic needs, we've seen what they are. We know that common knowledge, what it's going to do about these basic needs. We've discovered other needs that have emerged in the awareness of things happening around us today. What are we going to do about those things? What's evident is that we need to continue supporting moms, the impact on their infants, the children, families, and their communities. We have to reach for something better. Still today, too many babies are dying before their first birthday, and certainly low birth weight continues to be that leading cause, and preterm birth is increasing, and we know the impact, again, of racism in pregnant women. There are 101 Healthy Start communities, all with infant mortality at least 1.5 times that of the national rate of 5.9, and the majority of which are in communities where there's been a history of redlining in communities. Today, when I hear 5% or 25%, I'm reminded that the United States has 5% of the world's population, but 25% of the world's incarcerated, according to the Sentencing Project. Most of the men incarcerated are Black. According to data from the National Fatherhood Initiative, 92% of incarcerated men are fathers, and among them are grandfathers and sons. We have to reach for something better. Certainly, if we want to celebrate the triumphant parts of our past, we have to be willing to confront the negative parts as well, reaching for something better. With that, I would say hope. Healthy Start was the first community-driven, community-based program to address infant mortality, disparities in Black infant mortality particularly. In fact, the name of the Healthy Start when it was introduced was Healthy Start, a community community-driven approach to addressing infant mortality. I echo the words of the questions that came earlier of really engaging the community, but Healthy Start was the first program to emphasize community-driven approaches. A significant financial investment of MCH and for 30 years helped grow from 15 original programs, Healthy Start programs, and then 7 additional ones funded by the March of Dimes. We grew from 22 programs in 1991 to 100 programs today. Why? Because the programs are working. And the programs continue to work, and investments continue to be made in Healthy Start, as you even heard from Dr. Warren earlier. There's also a social return on this investment that's seen in the Healthy Start design, where each of these programs have a consortium, a community action network. And that's a guarantee that these programs are engaged in a community grassroots level. These resources ignite partnerships that help leverage and maximize resources in a community, and it encourages that change is sustained at the community level. The CAN, or the Community Action Network, has always been a required component of these programs, and it's what has made the difference because community has been involved. And in times like this, it's great that the community is already engaged. I was a young activist in Boston, where one of the original Healthy Start programs was in my neighborhood of Mattapan, one of the highest infant mortality rates in the city, and my second son, Austin, his outcome being part of that infant mortality statistic. I view the consortium as the heartbeat of the Healthy Start program because it involved the people and solutions to the problems that impact them. It works. Involving people in the problem directly works. So the heartbeat of these Healthy Start communities around the country, they're pounding the loudest, even in the wake of our current crisis. It's a great opportunity for Healthy Start to continue to beat with the sounds of justice and equity. This initiative is not new to this party. The Maternal Child Health Bureau and the Division of Perinatal Health Systems, official name for this program is Eliminating Racial and Ethnic Disparities in Birth Outcomes. This funding cycle in particular is focusing on life course approach, the social determinants of health, equity, and the impact of racism. And for the first time ever within a maternal child health framework, we've included fathers, partners of the women and fathers, and the infants that we serve. We've been reaching for something better for almost 3 decades. When we think about 400 years of enslavement, we think about 150 years of Jim Crow, there's been 85 years of maternal child health, 56 years of civil rights, but there's been 3 decades, 30 years of Healthy Start. So as we look back, let's leap forward and start reaching for something better. These times have further amplified and illuminated the disparities and inequities that always lie right beneath the surface, looking for opportunities to reveal themselves. And programs like Healthy Start and other MCH programs know how to pivot and innovate. I'm proud to be at NICHQ and an organization that is committed to the health and well-being of children. I'm happy that we're leading the Healthy Start TA and Support Center and working with the Bureau and the division and partnering with these 101 Healthy Start communities across the country. We're standing with them, Healthy Start strong. And Dr. Warren said a word earlier, together. We're standing together, reaching for something better. Next week, the Bureau and division is hosting the first ever grantees meeting with these 101 programs. And I tell you that it's been designed, enhanced and strengthened in its design by what's happening around us, COVID-19, as well as the racial upheaval in the country. But we're reaching for something better, Healthy Start strong. But again, I'm happy to be part of the panel today and look forward to the conversation. Thank you very much.
Thank you, Ken. Really appreciate that. All right, let's try again for Joya. Joya Kruperi, I hope you're on board.
Can you all hear me?
Yes, finally. Great to hear your voice.
Yes, great. Okay, now let's see if we can get this webcam going. All right.
Ken, if you could disable your webcam so we can enable Dr. Joya's, that'd be great.
We're good? Lord. Can y'all hear me? Hello?
Yep.
Okay. So where'd the slides go? Right? What happened to my slides?
Hold on, I'm not sure. Let me check with the Adobe tech. They were there a minute ago. Give me just one moment.
I'm like,
Sorry about that.
All
We're
the
seeing
joys
your
of virtual
screen share
meetings.
for some reason. Apologies.
No, I thought a thing came up and asked about me sharing the slides, and I didn't think I was doing that. So did you want me?
Yeah, we have them. I don't know where they went. We're getting them back. Just a second.
Okay, cool.
Sorry about that.
So thank you all so much. I'll just talk while you guys are looking for my slides. I am honored to be a part of this SACIM meeting. I've honestly, and following both Dr. Gupta and Ken Harris is a hard act to follow. I feel like they probably have said most of the things that I'm going to say, but there's not too many times, there's not too many moments where you don't, that you can't say racism too many times in a day. So it is important for us to continue. Okay, the slides are back. So it's important for us to talk about our work in the context of where we are today. Oh, I just want to take a breath because this has been a little harrowing trying to get here with you all, but I'm happy to be here now. And we're going to talk about the work we've been doing in the context of respectful maternity care and how important it is for us to have, going forward, respectful maternity care. So next slide, please. Or do I do it? Okay.
Yeah, I made you a presenter so you can advance on your slides, but I can also do it for you if you prefer.
Thank you. All right, so the mission of our organization, we were founded at a Healthy Start meeting with the amazing Deborah Frazier, who has been a mentor of mine since I was a small child, and making sure that I understood kind of the importance of grounding in community and making sure that maternal and child health is grounded in community. So it's great to follow Ken in the work of Healthy Start. But our mission really is to create solutions that optimize Black maternal and infant health through training, policy and advocacy, research, and community-centered collaboration. It's really that community-centered part that we've been missing so much in the maternal and child health field. And as a person who was a city maternal and child health director, I can tell you that we have not created a structure to include community in how we build or implement or evaluate programs when it comes to maternal and child health, except for in a few programs. So next slide, please. Oh, I have the control. I'm sorry. I did it myself. So today, I have had the honor of presenting at the UN in Geneva a couple of times now. And when you get outside of the U.S. context and really looking at some of the countries that have better birth outcomes than we do, they have a human rights framework. And we have not had a conversation in the United States about what that means. What does it mean when you have human rights? Some of our elders and some of my mentors fought really hard for us to have civil rights, and people are still fighting every day to get civil rights around access to LGBTQ and disabilities and around race. So when you have a human rights framework, you're not fighting for individual rights for each group. We start from the beginning believing that all people have the ability to live to their full potential. And that, so when you have that fundamental desire and that fundamental understanding as a country, as a nation, that all people have the ability to live to their full potential, you create infrastructure very differently than you do when you have an underlying principle of survival of the fittest. So about 25 years ago, during the first iteration of healthcare reform under the Clinton administration, there was a lot of conversation around reproductive rights. So as an OBGYN or as a healthcare provider, we do reproductive health. So that's the pap smears and hysterectomies and make sure that people have all the things that they need for their health. Reproductive rights are really the laws that dictate that, right? So I learned a lot of that when I moved from working in private practice to working inside of city government. So many of the policies around who can have access to sex education, how we decide where birth control goes, all those are laws and policies that are created at a city, state, federal, and international level. And so many of our reproductive rights are created through laws. But in that first iteration of healthcare, or in that last iteration of healthcare reform, there was a lot of conversation around reproductive rights and those laws, but there were Black women who really said, having access to birth control is not the ultimate for our reproductive freedom. That right now, I have a 9-year-old son, and I worry about him playing alone in a park with a toy gun, right? So for a Black woman, we worry about even outliving our children. So our reproduction doesn't end when we have a baby or if we have access to birth control. Our reproduction is our entire life. We want our children to have joy and to live a long life. So reproductive justice is the term that came out of that movement, and it's really the fundamental belief that we use in our work. There's human right to maintain personally bodily autonomy. So that means if I don't want to lark, I don't want to lark. I don't want to lark. You can't make me want one. I have personal bodily autonomy. It also means that if I want 8 kids, I want to have children, I can have as many children as I desire. I can tell you that for me, I have 3 children, and when they're all here together with me, I feel like the little old lady who lives in the shoe. But if people want to have more children, that is their choice, their desire, and we are not here to dictate those choices. To not have children, you should think about this. But we have policies in the United States where you don't qualify for insurance, for Medicaid, if you have not had a child. You are a child-bearing adult. That's who qualifies. In my own state of Louisiana, up until Medicaid expansion, so there are generations of people who did not have, Black and white, who did not have access to health insurance because they never birthed a baby. So this promising or highlighting or only believing you're valuable if your uterus is used to birth a baby, and therefore that's how you can get insurance, is also something that's not fitting inside the reproductive justice framework. And then the last one is really where we talk where my son comes into play, right? Being able to parent our children in safe and sustainable communities. And as Loretta Ross and others in the the founding mothers of reproductive justice would say, we can't let our reproduction, if you can't show up to our movements around Black Lives Matter, if you're not going to fight for us around justice, and we're not going to be able to continue to work only around reproduction. That all those things, all those different powers or intersectional questions are really important for marginalized communities, and we can only not just focus on one. All the intersection of all those are parts of our identity. So there's a difference between an indicator and a framework. And a lot of you, we've never really questioned under what framework we have our current indicators. So an indicator is a data point. It's a measurement that's limited by our current reality. It's a product of our past understanding of public health and science. And systems are more apt to adhere to specific prescribed indicators than to determine alternatives. So let's think of some of the indicators we currently use. For example, marital status, right? So we love counting who's unmarried and who's married. Well, I love my husband. He's super cute. But me marrying him does not improve my birth outcome. It's a proxy. It's a proxy for wealth. It's a proxy for having access to wealth, generational wealth. So if 2 people who don't have wealth get married, that doesn't make their birth outcomes improve. So if you want to calculate wealth and improve people's wealth, then that's what we should be counting, right? Pregnancy intention. That's another indicator that we love to count. We use it for all kinds of things. I intend to run a marathon, right? One day maybe. That requires me to one day actually exercise or walk around the block. So and we want people to have middle-class intentions without giving them middle-class support and middle-class access. So at some point, instead of us measuring pregnancy intention, we could think about other measures like pregnancy well-being. How do we support people in their pregnancy choices? What are we doing as a country and as a world to allow people to have mental health and the support systems that they need for pregnancy well-being? So then we have to question under what framework were those indicators chosen? A framework is a vision. It expands our current reality. It allows freedom to explore language and indicators. So to say things like, pregnancy intention has for 50 years been around and it hasn't tracked for anything except for maternal mental health, but it doesn't track for infant mortality or maternal mortality, so we could stop counting it and using it as an indicator, and look for alternative data collections like pregnancy well-being. And we should also question our historical instructions, right? Like, how do we come to decide that marital status and intention, what framework were we using when we picked those indicators? I can tell you that when you use a framework of reproductive justice, of human rights, or birth equity, you really pick very different indicators for how you're going to measure your success. Because success to get to a human right or to get to reproductive justice, or birth equity will not come through marital status or pregnancy intention. So birth equity, when we created our organization about 5.5 years ago, there weren't any definitions for birth equity. There were definitions for health equity, for equity in general, but not for birth equity. So we looked at all those different definitions and we created what really fits our mission and vision, and it's the assurance of the condition of optimal birth. So we don't want people to survive a pregnancy and say, oh, thank God I got out of that. Well, really, how do you thrive? How do we live our best lives, right? And we have to be willing to address both racial and social inequities in a sustained effort. So although we're super excited to have 5-year grants, it's a long time in the federal government, 2-year grants, 3-year grants. It took us 400 years to get here. It's going to take a long time for us to turn this ship around. So don't expect at the end of 2 years or 5 years that everything's all equal and now we've all solved things. However, we do expect to be moving towards some equality within that time, right? So we have to put the assurances, the conditions, the policies. These inequities were created by people who sit in the same seats where you all sit. Policymakers who work inside of federal government, state government, and local government created policies that were unequal for Black people, for women, and those policies have outcomes that cause us to have inequities in health based upon them. So the good news is y'all are the new policymakers, and y'all can make different ones. You can make different choices. You can look at different indicators to ensure that we close the gap, and we're not assuming that people of color or marginalized communities are broken. So what are some of these root causes? What's happening? How do we get these inequities? So this is a slide that comes from the Michigan Public Health Institute, which is adapted from Richard Hofstadter from at NACHO. And this is really, in 2005, when I was the director of maternal and child health in New Orleans, what was happening in the city of New Orleans, right? The president flew by and waved at us. But we also had the World Health Organization that came and sat, and I was a young person. I was much younger than I am now in 2005, sitting in the room, listening to these brilliant people from WHO talk about this idea of social determinants of health, that it wasn't your choices or your genes that caused differences in outcomes, but there are things like living wage, quality education, social safety and connection. And those things cause psychosocial stress and unhealthy behavior, which lead to a disparity in the distribution of disease, illness, and well-being. So this is super important, right? Because for the first time, instead of blaming and shaming communities of color and marginalized communities and saying, oh, well, you're just different, we said, look at these social determinants, these causes. This is what's causing unhealthy behavior. So we have childhood obesity, not because children just like kiwis, although I like kiwis, I think they're super good. The reason we have childhood obesity is not because kids just naturally like kiwis. We have it because we have food deserts, because we cut out having physical education in schools, because we don't allow, because children are stressed in their environments that have high crime, and we're not investing in the things in their communities that allow for them to live freely. And so you see the top of my slide is still empty, because what we haven't had a conversation around as a country yet is where do these social determinants of health come from? Not just as a country, as a world. How do we have some countries, some places, some people who have access to a living wage and others don't? And that is because we have a power and wealth imbalance. And those are things like our labor markets, our housing policy, our education system, our social safety net. In the U.S. context, we have 3 main root causes, which are racism, classism, and gender oppression. So although it's really important that we work on these social determinants of health, if we do not undo these root causes, we will continue to make programs and policies around the social determinants of health. So it's exciting that we moved up to this space of social determinants instead of blaming and shaming, but we really need to get into the root causes. For example, every woman that we interviewed talked about not having access to transportation in the United States. That's rural, urban, suburban. There's a big break when it comes to transportation. And so if you were only addressing the social determinants, you would give people access to Uber and Lyft vouchers and say, fix transportation. If you're really undoing the root causes, you would build a transportation system across the United States where people have the ability to move freely, not just for doctor's appointments, but for work, for play, all the things that they need in order to live. So how do we rethink just only focusing on these social determinants, but undoing the root causes and acknowledging the history of racism, classism, and gender oppression. So it's racism, not race. Right? This is a really important point. Okay. My stuff? Hello? Here we go. So racism affects our body both directly by chronic stress and indirectly through race-based discrimination across multiple systems, which creates differential access to high-quality schools, safe neighborhoods, good jobs, quality health care, and other words. And when we were able, with some funding through the Merck for Mothers, disaggregate data in multiple sites, because we knew when this data came out that Black women were dying in childbirth at 3 to 4 times the rate of their white counterparts, that what was going to happen is what always happened. We were going to be blamed and shamed yet again for these worse outcomes. But when you look at the data, Black mothers who are college educated fare worse than women of all other races who never finished high school. Obese women of all races have better birth outcomes than Black women who are of normal weight. So I can't even punchy my way out of it, right? Black women in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest ones. So we move to gated communities, and racism just follows us and finds us there. And this is one that is hard for my public health and my OBGYN colleagues to really absorb. African-American women who initiated prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. Because we love believing that we're the answer, right? If you come to the doctor, we can fix everything. And the truth is that is not so. That your health care visit is only 20% of your health, right? So what this also tells us that it's important. Of course, we want to go to school and get a good job and exercise and move to nice homes. And this is all of our public health strategies. We've only focused on what people should do. But when we do all of those things, when Black folks do all those things, we're still more likely to die. So at some point, the systems and structures have to change that are harming us. Because when we show up educated and exercising and you still see us and you still treat us as if we're broken, we're going to still have the same poor birth outcomes. So it's our time now to say, what is the system going to do differently? How are we going to really work differently? So we interviewed Black women around the United States around who had had an infant test around their experience. And the title of that article is Look at the Whole Me. We then created a birth equity index where we looked at about 50 different social determinants of health to see which ones had a positive predictive value for Black infant mortality. Some of them you would expect, like things like having obesity or smoking, and those are the typical public health strategies. But some of them you might not expect, like the higher the rate of air pollution in your community, the higher the rate of infant mortality. So a public health system could work on air pollution and improve birth outcomes. And that's not an individual accountability. That's actually holding systems and structures and institutions and businesses accountable for their harm they're causing on infant mortality in communities. Things like racial residential segregation had higher rates of infant mortality. And that doesn't mean Black folks just need to move to Black neighborhoods. That means we need to invest in Black people where they live so that they can have better outcomes and be able to thrive. This is the birth equity index. The worst city was in South Carolina, kind of blacked out here, and the best was San Diego. So instead of us all moving to San Diego, we really should look at what are the ways that what are the infrastructure that people are building that are allowing people to live longer. So what are some of our opportunities? So what's missing from the care of Black women is their centered voice, the validation of their experience, and freedom to choose and be informed. Black women need respectful care that is free of implicit and explicit bias. It is the provider's responsibility to address those biases. To address the issues of maternal mortality, we need care that originates from and is defined by Black women-led organizations, practitioners, and community members. And this is Jessica Roach, who is my co-lead of the CARE Working Group for the Black Mamas Matter line. We just recently had Black Maternal Health Week. This is a list of all the current partners and members of the Black Lives Matter Alliance. And really, we have members who are everything from researchers to doulas to midwives, physicians, policymakers. And so, as you probably know, we have the Black Maternal Health Caucus now, and so really pushing for policy change because race is a social and political construct, and so the policies are going to be the ways that we're going to end inequities, not through looking at my genes or figuring out if my telomeres elongate, because my telomeres and my genes have nothing to do with the reasons that I have birth out. We created a black paper, not a white paper. It's titled Setting the Standard for Holistic Care of and for Black Women. It's on the Black Lives Matter Alliance website. A couple of the organizations we work with, one here in D.C., Mama Toto Village, who's another strong member of the Black Lives Matter Alliance, and also Ancient Song Doula Service. Okay. My computer just died. Can y'all hear me?
Yeah, we can still hear you. It's interesting. I lost connection to Adobe a couple of times during your presentation. I'm not sure what's going on.
Yeah, I think it was an Adobe
That happened
issue.
to me also.
To me. I think it might have been
hear you the whole time. Okay.
But yes, we can hear you. We've been able to hear you the whole time.
Well,
right now the slide
still working, but my computer
right now the slide that's up that says respectful maternity care.
Okay, great. So I'm almost near the end. So I'll just say that we're working with the American College of OBGYN, who is our subcontractor, and the Johns Hopkins Center for Health Equity to create a respectful maternity care. We've interviewed Black women around the United States around what that could look like. It's a term that's used globally. The WHO has some standards for respectful maternity care, and so have they been working on it also in New York City with the New York City Health Department. And so really trying to socialize this idea. There are things that women want in their care. All women want in their care to be listened to be heard, to be valued, and those are things that have not been historically a part of how we take care of women. We really see ourselves as the authority for birthing people, and they should just listen to us. And so this is an important move for us to really start respecting the needs of others. Can you push to the next slide, because I still can't get back on. What does the next slide say?
It says birth equity during COVID-19.
Okay, great. So what we were able to do from the stories that we heard from women when we interviewed them and really linking through what respectful maternity care would look like, and then thinking about our current moment in COVID-19 and some of the stories we've heard. So pre-COVID, Black birthing people were already being policed around who could come in the room with them. I can even say for my own self, when I had my daughter, I was only allowed to have one person in the room with me. And so I had to choose between my partner and my mother. And so those are the kind of hard choices that Black birthing people have had to do and controlled and policed for a long time. So now you see during this COVID-19 crisis, the continuation, now that's expanded to everybody. And when you have scarcity, you see systems respond by saying, well, we can't have people in the room, and you can't have a partner, or you can't have a doula support. And so that's that feeling of scarcity. And really, we're hopeful that at the end of this, we will see that we're both been under-resourced, both the labor and deliveries, the hospitals. None of us have the things that we need in order to survive. And that having a partner there is not a fringe benefit. It's critical for us to have support when we have birth. When we have a baby, because birthing is a community event. It's a communal event. It's something that we share with others, and it's important for our growth. Okay, next slide. Can you hear me? Morgan?
We can
Hello?
hear you. I don't know if
What's the next slide say?
Segregationist, assimilationist, anti-racist.
It's our last. This is a closing story. We made it, folks. So my favorite book is Ibram Kendi's Stamp from the Beginning. I should start saying my second favorite book. My favorite book is my husband's book, Know Your Price, Valuing Black Lives in Black Cities. But this is going to be my second favorite book, Ibram Kendi's Sent from the Beginning, The History of Racist Ideas in America. And in this book, which you all should read, he has a new book now titled How to Be an Anti-Racist, and there's Baby Anti-Racist, and there's even a children's version of this. But anyway, he describes three groups of people. People are either segregationists, assimilationists, or anti-racist. And in the book, he follows several people, and one of them is Abraham Lincoln. And Abraham Lincoln is a really critical and important person in our history, right? He freed the slaves, excited to have him as the president. But imagine near the end of his presidency, he brought in the top 5 black people to the White House. And he sat them down. You can picture it, right? They get to go to the White House, and they're sitting there, and he says to them, hey, guys, here's $3 million. Why don't you go back to either Liberia or go to Panama, because a black or brown place, because both places he thought were not good places for people to live. Go back to those places that you need to leave. And so the black folks said, we don't think so. We've been here for 250 years, building this entire country for free. We feel like we should get the benefit of our labor, that we've been here and we're American. And he said, but guys, you're being so selfish. If you would just leave, the war would end, we can go along and have our white nation and everything will be fine. But the truth was, although Abraham Lincoln is a good and moral man and he believed slavery was bad, he also believed black people and brown people and indigenous people were broken. And so therefore, we had served our purpose in building this country and we need to go back to our respective nations. So much of our health care and much of our public health is built on this premise that peoples of color, indigenous people, are broken. And so if you are doing this work as a public health researcher, as a provider, as a policymaker, and you think your job is to save us because we are broken, we don't need you in this work. We need people who understand that we're all equal, we're all created equally, and that policies have been trying to break us. So we are in this together to make sure that everyone is able to thrive. And that is it.
All right. Thank you, Joya. Finally.
I'm trying to get back on, but I appreciate your patience.
Okay. Yep. We have time for a few questions.
Okay.
If people can somehow raise their hand or just jump in, I'm not sure that what I've got loaded with my Adobe is allowing me to see a hand raised at this point in time. Something's going on with Adobe. So if anybody wants to jump in with some questions, we'll figure out some way to do that. All right, now it's come on. All right. Raise your hand if you have some questions. I have a question for Ken. You talked about a healthy start, but as I look at the data over the last 80 years, the only times that we've really had a decrease in the disparities in infant mortality was during World War II and then during the early 60s, well, from 64 to about 70. What did we, and since that time, the disparity, black-white disparity has been increasing even after the start of Healthy Start. What should we be learning from those two times when we really had reduction in infant mortality disparities that could be applicable now?
Yeah, I think, and our colleague, Dr. Arthur James, talked about this a lot, but in the 60s and 70s, we had this infusion of resources into those communities. And then right after that, we saw policies that began to target these communities, black and brown communities, black and brown men in particular, as you look at the growth in incarceration. So those policies that began to go in place after those resources were put into communities, and then they were taken out of. And so I think that's one of the reasons why we saw, again, we know we can do better and improve, but then those resources were taken out.
Hey, this is Joya. Can I just build on what Ken just said?
Sure.
Yeah, and it's important for us to think about every time we've in the past had war or crisis, we do things to invest. We've not always equally invested we've never equally invested in black and brown communities, but they are opportunities that we choose to invest. So right now, this pandemic is yet another opportunity for us to invest and to do policy level things at a federal, state, and local level to invest in Black and brown communities that have been disinvested in. And so we could see that gap close like you saw after the Civil Rights Movement a little bit.
All right, we have a couple of questions. Janelle Palacios. Unmute yourself and ask a question or make a comment.
As a reminder, to unmute your mic, please press *1.
Looks like Janelle's phone is disconnected.
All right, how about Jean?
Janelle.
Jean Connery. Janelle or Jean, either one, whoever gets there first.
Wait, it's Janelle. Can you hear me?
Yes, go ahead.
Yes, we can hear you, Janelle.
Okay, perfect. Right when I was had back. So everyone.
Oh no, you're breaking up.
Oh no. Is it better?
Yep.
Yes.
Those two
words were.
I will ask my question really quickly. It seems from both Dr. Gupta's presentation and Dr. Joya's presentation that there is this, given that history has shown us this decrease in fertility during, the flu or World War, and then also with that, Dr. Joya just shared with us that there is this investment in communities of color. Maybe at this time when our nation is facing a national crisis of some kind, we're all momentarily viewed as human, possibly. But during these times when we see a decrease in fertility, it seems with Dr. Gupta's presentation that in going forward with COVID and this possibility that the U.S. nation will have a decrease in fertility but an increase in preterm birth and maternal morbidity, that maybe some resources should be really addressing women's decision for controlling their birth options or delivery and space timing options. And it seems like that would be a very important key feature to highlight or to support during this immediate COVID-related pandemic. Does anyone have any thoughts on that? Dr. Gupta, Dr. Joya?
I don't want to keep over-talking if Dr. Gupta wants to.
Anybody want to respond to that?
Yeah, I can go ahead until Dr. Gupta comes. It's important that we, especially right now, really make sure that women have the ability to control their fertility, considering that we're going to be in a recession for a while after this. So even when the pandemic ends, there will be less opportunity for having access to wealth and wealth building. And although it's also at the same time important that we invest in wealth building and use all those levers that we have at the federal level to invest in wealth building. But if we don't ensure that women have and working people and reproductive age individuals have access to all the things that they need to control their choices around fertility, that we will worsen their ability to rebound after the pandemic. And your other part,
any comments?
Yeah, go ahead.
Hello, this is Wanda Barfield. Just to answer some of those questions, some of the work that CDC and CHS is doing is to really try to look at collecting or planning some of the information on presumed maternal COVID-19 status, and they're going to be looking at that through birth certificate reporting. And they're hoping to also look at maternal COVID-19 counts by month and state, starting probably late this month, and that information will be on their website. They're also thinking about ways to look at vital statistics reporting in terms of some of the wording and formatting so that we can understand COVID-19 items within birth certificate reporting. and also some of the issues that you brought up with regard to issues around delivery, looking at timing, cesarean delivery, preterm births by month. They're going to be looking at that in the context of COVID-19, really, again, hopefully starting soon. And also they're going to develop a report on some of the changes in terms of the percentage of home births by month in jurisdiction, because we have been hearing that, maybe a hospital is a concerning place to be in the context of COVID, and so that are trying to understand where women are delivering. And also in the context of hearing from women, in the Division of Reproductive Health, the Pregnancy Risk Assessment Monitoring System, we're also hoping that we're going to have an opportunity to ask questions of women around COVID-19. So I think there are also other forums where we can hear from women and find out more about the context of their concerns.
Thank you, Wanda. Jean Connery, you had a question. Jean, let's see if we can get you in here.
Can you hear me now?
I can hear you.
Perfect. Thank you so much. I just want to congratulate all the speakers this morning for a very interesting and dynamic session. It's been very eye-opening and very rewarding. Dr. Gupta, I appreciated your comments about the international importance of registries, so making sure that we're all aware of those. And I would like to offer up at FIGO as having a website that is listing all of the registries. We'll talk about that this afternoon, but we do have a site that lists every registry as people say it's important. And let us know, and Dr. Barfield especially, knowing that we have registries taking place. The most important ones are those where the data are collected across the entire country, rather than optional sites that are taking place. Dr. Keir-Perry, I want to thank you so much for your focus on a human rights perspective. With that framework and universal health care, I think that's the way we need to be, and that's the only way to go forward. So keeping that as a backdrop for all these discussions, to me, is absolutely critical. And then finally, with the perspective from some of the comments that we heard with Dr. Michael Warren on the upstream approach is well women health care. So making sure that we're looking at the health and well-being of women. So if and when they elect to conceive, and the if or when is there, we have a healthy pregnancy. Thank you very much.
Can I just respond to Dr. Connolly? Is that okay?
Sure.
Yep. So thank you so much. I love following the work that you do in the UK, and the importance of having also the collaboration with midwifery, and it's going to be really important for us here in the U.S. as we build out and move forward and more robustly. And we are the only high-income nation that has not agreed upon that health is a right. And we get stuck in the how to get to health is a right without us agreeing that that's our vision as a country. So I do hope that this pandemic will allow for us to really start embracing that we know that everyone, that we're one, if one of us is sick, all of us are sick. The virus is proving that to us. It doesn't matter your income or your education, and that we have to agree, we need to agree that everyone is valuable and should have health as a right. And then we can work on, well, how would we get there? What are the ways? There's a lot of different models for that and a lot of different labels for that. But I hope that all of my fellow colleagues will agree that health is a right.
Agreed completely. Thank you so much.
Mm-hmm.
Any other questions from the crew?
This is Magda Peck. May I, Ed?
Yes, go ahead. Go ahead.
Thank you. I just want to thank all three presenters for pushing to the norm and to the center the centrality of racism, and it's the starting point. It's not an if, it's a how. So thank you very much for that. A particular question, Dr. Joya, if you would, your slide specific to the one that said indicator does not equal framework.
Yeah, yep.
Brilliant, and thank you. We've known each other a long time. I just want to thank you so much for elevating and clarifying what's on the left side and what's on the right side. And so toward that end, I have the privilege of, well, many. Here I have the privilege of co-leading the Data and Research to Action work group that will be convening and deliberating later this evening or late afternoon, depending on one's time zone. And so this is I just want to thank you for this gift. I'd like to see if you could go a little deeper on your right side under framework, where it says, allows freedom to explore language of indicators, because language is narrative and language matters. And peppered through our discussions this morning, we've heard a shift to the language Dr. Gupta said of people being pregnant. We heard the shift to Latinx. We heard the shift in terms of reproductive to larger human rights. We've heard the shift in embracing and defining what is a birth equity index. So if we're going to reset the social DNA, if you will, of our efforts to eliminate maternal mortality, promote women's health and equity, and have all babies blow out that first birthday candle, can you tell us a little bit more what your wish list would be around what language we use in SACIM, which can accelerate that new lexicon for this movement? And I'll be grateful for that.
Yeah, so that's a great question. Thank you so much. So that's why I tried to talk a little bit about pregnancy well-being, and I try to give that as an example of what would be the difference between if you were looking at a framework of human rights or a framework of reproductive justice or a framework of sexual and reproductive well-being, then if that was your actual framework for what your vision was for human beings or for Americans or for the world, then what are the indicators you would use to get there? And so pregnancy well-being, reproductive well-being, these are language, these are new words that we're starting to build out in some of the work that we're doing with my colleague Christine Dellendorf at UCSF, and with some of my colleagues. I don't want to drop too many names and I'll miss some people, but really, if we pick, say, pregnancy well-being, which is a term that we're using at the National Birth Equity Collaborative, then you would build a system that says, okay, if this is our indicator for success, then what are some things people need to have pregnancy well-being? They need access to mental health care services because we don't invest in postpartum anxiety or depression. We know that they're both under-resourced and they're underdiagnosed because of we don't invest in the resource to address it. And so we would then create a system and a structure that ensures no matter a person's first choice, that they have pregnancy well-being. What we do now is say, because you're poor, or because you're not in a community that we desire and we think should be procreating and having more children, or because you are, whatever reason, that we think you should make the choice, your intention should be not to get pregnant. So we then try to give you birth control to make sure that that does not happen, or make you as an individual make a choice without ever investing in the things that would create a well-being for an entire country. And so then we see outcomes like premature birth, like higher rates of maternal mortality, because we are not fixing the infrastructure that allows for people to have pregnancy well-being globally. Does that make sense, Magna?
Absolutely. Any other advice you would have for us would be
I think
from all speakers. So
well, I tell you what, I'm in a lot of measurement data committees right now, and we try to, almost all of them start so much in trying to pick measurement without looking at what framework their measurement is coming out of. So I just want people to take a moment, and I'm going to be really honest that I would say the framework for most things in healthcare has been a hierarchy of human values based upon gender, race, age. So everything that we pick is ways to keep that hierarchy in place. So if we want to get rid of that hierarchy or get rid of racism, classism, and gender oppression, we really have to look for our framework of freedom and justice. What are the things we would measure to get there?
It's a good way to end this conversation. This has been great presentations and great conversation. Been going on for a long time, but we need to take a little lunch break. So thank you all for the great conversation and questions this morning. And let us take a half-hour break, and we will be back at 2 o'clock Eastern Time for our open conversation with Michael and others from federal agencies about MCH, and you'll be able to share some of your perspectives. So we'll see you back in a half hour.
Thank you all.
Thank you. Thank you.
Thank you for standing by. As a reminder, all participants are in a listen-only mode until the question and answer session of today's conference. At that time, you may press star 1 to unmute your mic to ask a question. I'd like to inform all parties that today's call is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the conference over to Mr. Ed Ellinger. Thank you. You may begin.
Right. Good afternoon and continuing good morning for those on the West Coast. We made it through the morning despite all of the technical difficulties, and I'm learning as we go. I wish it wasn't this hard, but it is what it is. And if people could mute their lines and then just unmute them whenever you're talking, that would be great. I built into the agenda time right now to really have an open conversation. We heard from Thomas Engels, the HRSA administrator, and Michael Warren, the MCHB head, and we have, I'm hoping, I know we have Wanda Barfield from CDC on, but I'm hoping we have some of the other ex officio members from federal agencies to really, and particularly for the SACIM members, to really bring up the issues that you're seeing in the communities from where you live and work. To have this open conversation, because I want the feds to know what the community folks are seeing and hearing and learning, and also find out from the feds sort of what others are doing, what other agencies are doing. I did ask several of the federal agencies to give us an update on what they were doing related to COVID, and we got some really good responses back from several of the agencies. So I hope that you've had a chance to look at those. But let's just open it up, and then you can either put things in the chat, or you can raise your hand, or you can just jump in to see what kind of a conversation we have. And I'll just open it up in terms of for our federal partners, and really just ask the question. I'm seeing, or the statement here, I'm seeing that, as I said in my kind of opening remarks, with COVID identifying all of the deficiencies in both our public health and our medical care system, and then the racial justice protests that have come on, that have just shown the really deficiencies in our whole socioeconomic structure. It's having people in our community really look at doing new ways of thinking. So in my community, defund the police. I mean, it's looking at a totally different paradigm, a different way of doing things. And I'm just seeing this as an opportunity for us to take advantage of that openness that seems to be there in the community to do things differently. Because obviously what we've done for the last 30, 40 years related to disparities in maternal and infant health hasn't worked, so we have to do things differently. And so I'm wondering, are the feds seeing the same kind of thing, saying, maybe we need to relook at what we're doing, and are there some opportunities to do things differently? So that's just sort of an opening salvo of this conversation.
Dr. Ellinger, this is Morgan. I'm going to switch into discussion format so other committee members can share their cameras if they would like.
Okay. All right, so we're going to put you into discussion mode, so if you want to share your camera, you can actually, we'll be able to see you, which I hope we can. So turn on your cameras, raise your hand, jump into the conversation. Good to see some other people. Finally. Dr. Barfield, let's see, since you're the first one that came on the screen, give us an update of what you're seeing. What are the issues that you're seeing that we need to be aware of?
So today's MMWR talked about the large disparities that we're seeing in COVID-19 in Atlanta, Georgia, for Black versus white patients in terms of hospital admission and severity. And I think that that's just one highlight of the issues that, COVID is highlighting, that disparities were already there, but we're seeing an even greater issue. And with all of the events that are going on around racism and unjust treatment, I think that now we really have an opportunity to look at this and to
to study this more carefully and then think about the programs that will really help and support things in a different way. And so, as some of you know, I'm within the National Center for Chronic Disease Prevention and Health Promotion, and a lot of the populations that we're caring for include, minority populations, but also those with heart disease and stroke, those who are at risk for obesity, those who are at risk with regard to aging. And so all of these issues are really coming to bear in light of COVID-19. And so how we can think about it is to really hear a lot from the communities as well, the communities that we serve. We're thinking about how we can modernize our data system so that we can do these issues much more rapidly. How can we hear much better from communities? And so there's a lot that we need to think about right now.
Right. And for the group, Dr. Barfield sent some information out, and we shared it with you last night, so you should have those slides that she prepared that gives a lot of information of some of the things that are going on. And I do have to highlight the fact that Dr. Warren has to leave at 12:20 or at 2:25, so he will be here until that point. And I do want to ask Kara, since you had your hand raised several times during the morning and we never got to you, what comments did you want to make? So we still got to, we'll get your voice here sooner or later. Keep trying. Try *1. Can't hear you. I can't tell on the screen which one.
While we're waiting for Tara, I think, we do have an opportunity now to really still continue to look at issues around maternal and infant health that are really affecting particularly African American and other minority populations. And I think that this is really important and that we should still stay steady in our focus on some of those issues. But now I think we understand that there's a lot that we can do in terms of thinking about issues of communities, issues of quality of care, other factors beyond hospital treatment. I really appreciated what Joya was saying in terms of thinking about respectful care. That's an area that we're looking at in the context of maternal mortality review committees at CDC, and how we can really look at issues with regard to racism and how women feel that they're being treated. We're also looking at a national campaign that will also bring awareness in terms of listening to women's concerns. So I think there's a lot of new and different ways that we can approach this.
All right, good. Kara, let's try again. Can we hear you? No. All right, Belinda, I know you had your hand raised.
I did. I was wondering on a couple of things, because I know I'm familiar with the campaign that Dr. Barfield just mentioned, because we've been waiting for it to come out in North Carolina. And I know one of the things that we're looking at with our Maternal Health Innovation grant, Dr. Warren, is around, having some listening sessions with women. And one of the reasons is because we stood up telehealth services so quickly. We were having conversations in our state around how to do, how to strengthen our telehealth work, and then COVID hit before we could actually reach out to women themselves to find out, how do you feel about it? How do families feel about it? We knew there were a host of barriers around broadband access, not wanting to use your, not having access to cell phone minutes and things of that nature. And so we're getting ready to do the listening sessions, but some of our anecdotal information we're hearing already has been around, it's been a mixed bag. Some people really like telehealth services. We're hearing from some of our providers, they really like it. They feel like they have more time to spend with their patients when they're doing telehealth services, and it's more focused time. And so anecdotally, we're hearing mixed information, but I think the listening sessions will give us better information. But we are still hearing from anecdotally from pregnant women, and because it takes us about a year to determine if our home births are going up, our nurse midwives and others are telling us to be on the lookout for home birth increase. And I don't know if you all are hearing that. We have, on our end, if it's a home birth, they have a year to submit their, to turn in the birth certificate. So it may be a year from now before we know if our home births are going up. But wondering, are you all hearing that? And then Dr. Barfield, if you can share a little bit more around the pregnancy surveillance related to COVID, because I'm hearing it. I know we talked about it on our Region 4 call this past week for AMCHIP, and I think we only had one state that was participating. And so I'm also wondering, is there a way to get more states engaged in that and maybe share that information if that is a priority?
So I think I will ask Danielle to talk a bit about some of the work that NCHS is doing in terms of trying to monitor out-of-hospital births. But with regard to work with states, as you probably understand, a lot of state health departments currently are really taxed in terms of their need to respond to COVID-19 and also to currently maybe even redirect staff to focus on other areas such as contract tracing, and those are really sort of important acute issues. But we are trying to do our best in terms of supporting states by seeing if there's an opportunity that we can get questions out in the field that will ask some of the questions around COVID-19. It's still, in the works, but it is really important to get, how women are dealing with this particular issue. What are some of the practices that are going on that are important to prevent disease transmission?
Danielle?
Danielle said that she was having some technical difficulties. Right. Yeah. So
I can give a little.
Yeah. So Michael, talk about the home birth.
Yes. Yeah.
Yeah, so I think part of Belinda's question, the first part was directed to NCHB too. So I appreciate you all using your state innovation funds to do that. That's exactly what those are for. And I would be remiss if I didn't point out the flexibility. Our largest flexibility is the block grant, which gives states and jurisdictions the need to respond quickly to emerging needs in states. So that's another opportunity. And to some extent, Healthy Start has flexibility, and certainly we'd want folks to engage their project officers, but the goal is to improve both infant and maternal health, and so there's flexibility in communities for how to do that. I think it raises a big issue that we in the Bureau are looking at critically at how do we create flexibility to be able to respond nimbly to emerging issues? Because I mentioned earlier legislative authorities, and the reality is, we as a Bureau can't give out money for reasons that aren't specified in our legislative authority. We are bound by law to spend that money on the things they're appropriated for. And so we're very interested in looking at how do we work within those and be flexible to meet emerging needs, and also recognize that grants typically run in 3 to 5 year cycles. And so how do you as a federal agency build in that ability to be nimble and responsive, recognizing that you also make those commitments through grants and programs? So would welcome y'all's feedback as we think through that. But glad you're doing your state innovation work that way. We would love to hear what you're hearing back from folks. We can certainly share that with our other telehealth awardees, those 4, but also with the other state health innovation grants.
Thanks. Danielle?
Thank you, Bob.
Were you able to get connected?
Can you hear me?
Yep.
Yes. Yeah.
Okay, sorry about that. I, for some reason, can't do the audio on my computer, so I have to call in, and then I can't hear exactly correctly. So NCHS is attempting to do a few things with states in terms of collecting data on birth certificate data. I shouldn't say unfortunately. There are only a handful of states that are going to be working on this. We have found out that there are a couple more that are trying to get something going on, but one of the issues that we do run into and that we do acknowledge is that it does take us a lot of time to get the data out and get clean data out. So I do know that some states are trying to put out COVID-related data. One state, for example, would be California. I believe they started or they were about to start releasing data more frequently. I'm trying to remember what part of the other questions were, but I can't.
I was just wondering, are many states actually participating in the pregnancy surveillance?
Oh, the pregnancy
around
surveillance.
COVID.
Thank you.
So I can answer that. Yeah. So with regard to PRAMs and COVID, at this point, currently, again, several states are limiting their operations because of their need to actually respond directly to the response. But we're hoping that we'll be able to get things started. And there is a PRAMS NOFO that's currently out in terms of the announcement, and that will be another opportunity we see to address COVID, as this issue will likely not go away, and those applications are due August 11th. And if folks go to the grants.gov website, they can see the application for the Pregnancy Risk Assessment Monitoring System, or PRAMS. There's also
Steve,
other. Oh, no, go ahead. Sorry.
Steve had his hand up, so I thought you were done. But.
That's fine. Can you hear me?
Yes, I can.
Good. So just anecdotally for Wanda and for Danielle too. So I work with the birth center and midwives. I'm pretty in touch with the out-of-hospital community here, out-of-hospital birth community in Minnesota. I don't think we're seeing a lot of out-of-hospital births occurring. That may happen in other parts of the country, but we've had a real increase in interest in accredited birth center births where mothers are wanting to come. We follow CDC guidelines as well. We have been more flexible as far as having partner father, with a mom plus a doula, because we believe doula services are essential. And so we're noticing that, if the reality had become an overwhelmed healthcare system around the country, and it didn't really even happen in New York, then I think we would have had, something where you would have had to set up a whole bunch of other alternative sites for that happened. But it's really caused a change in mothers' desire to be away from the system, although they're very well happy to be cared for by the safety net of the system. That's incredibly important too.
So, Steve, I think you bring up an important point, but there is variation in terms of the availability of birth centers, by location, and so that may be another issue. And I think, Joya's presentation alluded to that.
Yeah.
Jean Connery has her hand up, but I don't see Jean's face or her square on this. Jean, are you hearing us?
I can hear you and can't get my picture to come up, so I finally gave up on that.
Okay, so just
thank
talk.
You very much. I'll talk. There's probably one other little button I'm supposed to push, and it keeps saying start, but it doesn't, so I apologize. I think what I heard very clearly, and what I'm still hearing, is this speaks to the absolute importance of not just a voluntary registry, but registering all of the information about every delivery across the United States. If we're going to go back and look at COVID outcomes without having to be selective or looking at voluntary input of data, it's going to be a national registry of births. When we're looking globally at where we're getting the best information, Germany is awesome. Australia's got a great registry because they already have every delivery, the Nordic countries. So I think looking forward, and Wanda, I'm sure with all the research that you're always doing, it could be one of your greatest laments, but this speaks so strongly about why we need not just the birth certificate information, but the details on every delivery and some critical information about the prenatal care.
So you're bringing up some important points, and okay, I won't whine about the lack of longitudinally linked data that the United States desperately needs, but there is some work that's going on. So you know, within the response in COVID-19, we are supporting pregnancy surveillance and maternal and infant health studies, and that's being done with our division in collaboration with the National Center for Birth Defects and Developmental Disabilities. And they're also doing some work on surveillance for emerging threats to mothers and babies called SETNet, and trying to do a lot of work to characterize the epidemiology of COVID-19 in pregnancy and infancy. But we're also supporting various networks through, you know, clinical groups to include AAP and Vermont Oxford Network to look at the information that they're collecting. So really welcoming lots of different opportunities. With regard to the national piece, one of the steps that we're doing is in collaboration with ASPE and looking at a linkage of PRAMS data and hospital discharge data for several states as a pilot project to try to get more of that broad spectrum information around pregnancy and delivery that you're mentioning. So we're trying to move forward on that, and that's a PCORI funded project.
Michael, I know you have to leave shortly. Are there any issues that you want to raise or any questions that you have of this group prior to your leaving? And I know you'll be back later for the rest of the meeting, but anything you want to raise now?
I'm curious if there are ways that you think we can, as we approach fall and as folks think about going back to school and resuming childcare, the impact on mothers and families and what considerations we need to be thinking about there. Clearly not all of those things are within our lane or CDC's lane, but there may be other federal partners we can share that information with. But what are those other sources of stressors? As there may be moms who have been able to telework thus far and now are being asked to return back to work, what is that looking like? So I think as we're seeing those shifts as maybe social distancing requirements or stay-at-home orders are being released, what are those shifts looking like on the ground, and what are those real-time impacts on kids and families? We would love to continue that dialogue with you all. And I will be, like I said, I'll be out of pocket from 2:30 until about 3:30, but I'll be joining you back after that.
All right, thanks, Michael. And you do bring up a couple of issues. Certainly what I'm hearing, a lot of child care issues and how important that is. And then also just broadband, given the fact that we're doing this virtually and so many other things are being done virtually and telehealth is there, the lack of access to adequate broadband is turning out to be one of those social determinants of health and we have to pay attention to that. And then certainly the other issue that we're seeing is, particularly in our immigrant communities, is the decrease in vaccination rates, you know, again, because of COVID and access. And so those are the issues that I'm seeing, you know, child care, vaccinations, broadband, as among other things that are just front and center.
Yep. And as I'm hopping off, I'd be remiss with your last comment. I'm getting a lot of feedback. I think someone needs to mute maybe. We launched today a social media campaign, #WellChildWednesdays, to address the decline in immunizations and well child visits. So if you are on social media at all, if you could help us amplify those or have your organizations amplify, that it would be great. If you go to the HRSA social media feeds, you'll see those and you can retweet or share. And then use that #WellChildWednesdays. But appreciate our colleagues at CDC raising attention to that a few weeks ago in an MMWR. Lots of interest in that.
All right.
See you in a bit.
All right. Magda, you have a question.
Yeah, everybody's going to have technology issues at some point today, so it's my turn. I take it willingly. So I am here. I am curious about, beyond the generic or beyond the broader populations that are being greatest impacted, what are we hearing about incarcerated women, around women who have housing instability and as eviction holds come off in terms of housing insecurity, or in homeless shelters or hotels to bring back that bottom line? What are we hearing on the border around contained children and women and families in limbo. So I want to push the question about some very specific, in Michael's words, vulnerable populations whose vulnerability is amplified at this time in the era of COVID. And how are we measuring and monitoring the disproportionate impact on those that have greater crowding, greater risk? So anything that you have on the ground on that would be very helpful, because now is the time not to forget those who are structurally marginalized and made more invisible.
Thanks. I'm not sure if any of our federal partners want to comment on that.
Yeah. So, Magda, I don't have information about incarceration, but I think what we are learning in terms of some issues are what is going on for tribal populations, particularly in terms of issues around housing and housing size and challenges there. And there are real challenges in terms of the practical implementation of, guidance with regard to social distancing and other things in that context, in those communities.
Yeah, and Magda, you're sort of leading up to a part of our conversation about the recommendations to the Secretary, because the 9th recommendation we had was about data collection during this time of COVID.
Yep.
That will, I think, if we want to be more, maybe even get more specific on our recommendation to raise some of the issues that you had about data collection for those populations. Janelle, get your hand up.
Oh, perfect. Okay, so let me mute everything. Can you hear me?
Yes.
Okay, perfect. Okay. Yeah, just to echo the different social structure systems of families that cannot shelter in place or that have multi-generational family members living with them, or even, for example, in my county, 75% of the people who have COVID is actually the Hispanic Latino population, and it could be largely because of the factors that this is a population that they are, they have to go to work. They're in a service or different communities or different businesses where they are mandatory workers. They may also be, living in multi-generational or multiple families in one household in one shared space. And this is, and then, a leading use of child care, especially during school time, is school, right? So we have now families that have all these people that can't appropriately socially distance and that move around the community pretty quickly. So being able to work with communities and cultures, for example, American Indian, Navajo, Diné culture where families are together, will be interesting to see what community organizers or community health workers are able to help inform or help find culturally appropriate or socially appropriate ways to help minimize COVID exposure and spread. And then we also have to think about, I think this is something that we've all kind of considered, like reading articles and watching epidemiologists kind of predict that we may have a future surge up ahead of us. That right now we have maybe a lull, but there may be another surge coming our way, and especially with fall looming and possibility of children going back to school, and for the state of California, that actually is not necessarily, we're going to have children go back to school, but it's going to be a hybrid system. It's not going to be children back in school as they used to be. It'll be social distancing school and education.
Mm-hmm. And Steve, you had your hand up earlier.
I think Janelle was still talking and we lost her.
Oh, sorry.
Maybe not. It may have just been delayed on the monitor.
Okay. Steve, did you have a question or a comment?
Yeah, it was just, again, when Michael, when he comes back, it was, as you were talking about some of the challenges, the child care and other things, we have a fairly young group of midwives, and they're if we had a midwife or two go out, we would really have trouble serving the community that's seeking care. And so I was just going to ask him, the HRSA for however to increase the number of midwives. I know that's a long-term question, but there are issues regarding training of midwives and support of training of midwives. I'm sure Janelle would understand that, and so would some other folks on. It's Ellen Tilden from Oregon Health Science University too. But that's a question maybe to ask Michael when he comes back.
All right. And I see Belinda has her hand up, but I also want to question of Belinda and Janelle is that a lot of the issues that we're seeing are going to be decided at the local level for sort of supports for a lot of these things. Who's working with city council members and mayors and state legislators and governors to actually push the policies that are going to be needed to address all of these issues? We're making recommendations to the federal government or to the HHS secretary, but a lot of these issues are really going to be state and local. And Belinda, are you in North Carolina? Who's working with the policymakers at where the rubber hits the road, more or less?
Well, in North Carolina, the leadership for our COVID response is coming out of our Department of Health and Human Services. And so, we're in constant contact through our secretary with the General Assembly and others. But the other thing is we have set up a host of teams within our department, and one that we've spent a lot of time focused on is historically marginalized populations and how to do, especially around how to reach communities of color that are definitely impacted by COVID at a different level. And so if you take the work we're doing with our historically marginalized populations and then you lay on the fact of issues of racism and the stress associated with it and the different level of stress that women of color who are pregnant are dealing with now, that's a gigantic piece that we are trying to get a better handle on and figure out. But we are in conversations with, our General Assembly. This is an election year, and so, it's interesting conversations when you're dealing with an election year than with some of the other ones. One of the other things we're hearing from pregnant women is, and I think, Ed, you mentioned this earlier, or someone did, is the whole issue of, each hospital system in our state has decided differently as to whether they will allow a doula support person come in with mom. Each one has done it differently, and so we've got a handful of hospitals that will allow her this extra support, and we have other handful of and others who won't. And when you're looking at 85 birthing hospitals and that much variation and trying to get people all together so that to make a similar decision, it has been a challenge. But you're right, a lot of this is we still don't have budgeted all of the federal dollars that are coming into our state around COVID. Some of it has been budgeted by our General Assembly and and our governor, but some of it has not because we're still trying to figure out and get feedback from people in our communities as the best way to use some of those federal COVID dollars.
Mm-hmm. All right, Lee, you had your hand up.
Can you hear me now?
Yes, I can hear you. Good.
Okay, thank you. So, Steve, just to comment back for HRSA on the question that you had raised around midwives, there are a number.
What time, John, on Saturday?
There are a number of, I think somebody needs to mute their phone. There are a number of issues that we're working on from the HRSA perspective around this issue. First of all, as Belinda had talked about a little bit, our MHI activities are focused on states providing innovative solutions within their states, and we know that some of the issues and restrictions that might be in place in bringing on nurse midwives or using them fully are not really at the federal level, but at the state level. And so hopefully some of those initiatives are working on ways to help nurse midwives, and other paraprofessionals in the perinatal space to be able to operate more fully. We are embarking on a series of new health workforce type activities with the idea that we would then be able to fund and support the training of nurse midwives. And as you stated very observantly, that some of these initiatives are not something that is going to resolve that issue in the next 6 months or year, because there's a lag time for the establishment and the training for those types of programs. So we are working in that area. We're also working on institutional initiatives where we're trying to embed within training programs additional supports and trainings on issues that could help people retool into that sort of care. So there's a lot going on, but we're also mindful of the fact that there is some disagreement as to who should be qualified, separate from what's going on at the state level. In delivering this sort of care, there are some long-standing beliefs and preferences about what the training is necessary for providing this support. And I'd like to believe that all of the parties are operating with their own perspective on what best intentions are for the way to deliver that care, but those are some of the other more sticky, sometimes political issues that we're trying to deal with. So I'm not sure if that's helpful, but.
Yeah, that was very helpful. Thank you, Lee.
Thanks. Lisa. We're not hearing you, Lisa.
As a reminder, to unmute your phone, please press *1.
All right, Lisa, well, can you hear?
I can hear you. Can you hear me?
Oh, yes,
now. I can.
Oh, okay, good. Sorry about that. It was the *1 thing. Thanks for having this meeting and this great discussion. I wish I could offer more up on the underserved issue. I didn't prepare anything for that, but I know that we have at ACOG our underserved committee, and I'm sure that they're tracking all this. So I can go back to them and see what they've heard and report back through email if you'd like me to do that. Regarding the grassroots efforts on telehealth and who's talking to the governors and at the local levels, we are initiating a widespread collaboration with our state section and districts on getting the COVID telehealth leniencies permanent in the states if possible. I mean, the federal government did a lot, but it's at the, like you mentioned, it's at the state and the local levels that all this has to continue. So we are working with our sections in our districts to talk to the right people at the right place. And it's different for every state, as you can imagine. One of the messages is also making sure that people have the durable medical equipment they need to be monitored appropriately at home. That's really important. And we've made pretty significant headway in that over the course of COVID. We know of several private health plans that are including durable medical equipment and sending those to pregnant women. So that's been helpful. We're also in conversation with all the big private health plans, you know, United Healthcare and the Anthem and Cigna and many others. And we have one-on-one conversations scheduled within the next 2 to 3 weeks with their medical directors on how we can partner to make sure telehealth continues appropriately after the public health emergency is finalized, whenever that would be.
Good. Thanks, Lisa. Janelle.
Sorry, can you hear me? Perfect.
Yes, I can.
Okay, good. So it's just listening to through our discussion, and thank you so much for clarifying and making it wide known, Dr. Wilson, just regarding the number of kind of red tape with and political issues around statewide recognition for healthcare providers and who is qualified to care for women. One of the issues that the institution I work for is looking into is how to actually partner with doulas, right? How in this time during COVID and women different hospitals are deciding who can have their partners or not have anyone with them while they're laboring. What do we do to help support women? And so we've seen some women, we've given women some iPads so that they can call someone and do FaceTime with a doula that they were working with or a beloved family member or friend. But as we go through COVID and hopefully we can have a different kind of normal, we are looking to increasing doula use throughout our institution, throughout our hospital. And we're wondering how, and this is also coming from a perspective for myself, but how can we, the steps needed to help reimburse doula services as a path and avenue for women who are definitely vulnerable. As we know, if someone who is paying for a support person like a doula privately, it can be very expensive, especially in the Bay Area. It can be $5,000 to $10,000 just to have someone who has experience doing support during prenatal and intrapartum and postnatal care. So looking at, I guess, the different policies that we can look into of how to support women during this time with perinatal health care, of especially intrapartum care, the delivery with doulas. And then are there any strategies or thoughts of how to have trying to increase the number of midwives or providers in this country to help care for women, maybe looking at how to, I'm sorry, I think, I don't know.
We can still hear you.
How to help increase the number of midwives through other means of, I am so sorry, I think I'm so nervous that I'm having a moment here. So let me collect my thoughts.
Now you know how I feel trying to run this meeting virtually.
Ed, you are amazing. You're amazing, Ed. I'm reading through my notes really quickly. Right. I think that if we can, so what does the data show us as far as Steve has brought up the issue of the, was it the Healthy Start research that looked at birth centers, right? So looking at prize-winning research that looked at alternate modes of care and delivery for women and how to spotlight this. Also recognizing that when we compare ourselves to other European countries, for example, like the Netherlands and even England, and looking at their birth outcomes, just knowing that definitely there's different societal issues, but they also have very strong one-to-one individual-centered woman care when it comes to delivery timing. They often have devoted midwives, nurse midwives with them linked to that. And how can we try to rise to a standard where this is something that we can implement in our country? Okay, I'm done.
Thank you. Magda.
First of all, it's good to see you all, and it's good to be seen. Thank you, Jeannie, for being the tech wizard that we've been doing behind the scenes troubleshooting. Go West Coast contingent. There are two additional points I'd like to raise up, and I'm trying to figure out where they park for further consideration and opportunity. The first has to do with qualitative information. It came up during Dr. Joy's presentation. It came up and in Ken's presentation, and it's come up here about elevating the voices of women and some special studies that are going on. And I want to underscore from the Data and Research to Action work group that when we break out, we will be trying to elevate up the methods and approaches within women-centered care, within family-centered care, to hear those voices. One example is that the Fetal Infant Mortality Review coming out of the Michigan Public Health Institute and the National Center is embarking on a storytelling project, which is borrowing and learning from Black Mamas Matter Alliance about how the maternal interview can now be layered with an opportunity for both the capacity for storytelling as well as elevating up her or his or their stories directly. So I just want to talk about valuing at this time when we're waiting for the data systems change to happen to hear her, his, and their voices, point one. And then point two is a little darker. I've been working with folks at Harvard on the misinfodemics work, the work of understanding that the disinformation intentional campaigns that are happening on our social media platforms, which are undermining confidence in public health data and systems, and which are giving, particularly around anti-vaccine, a greater amplification to doubt. And so I think we need to be extraordinarily mindful in our work about the opportunism of misinfodemics, or the opportunity to exploit how people get the majority of their information on Instagram or on Facebook or on other social media platforms, and how that is now an intentional campaign by some with an agenda that is not our own. And so I'm wondering how we can add to our data and research for action an awareness of the intentionality of nefarious acts that seek to disrupt, dispute, and essentially discount our data systems. And I'd like to know if you have comments either on stories or qualitative data and how they can be helpful now, and or if you have any sense of systematic monitoring and surveillance of misinformation that our women and children, families, and fathers are consuming.
So you've got a good agenda for your work group with those two issues.
Before I take it there, but it would be helpful. Like, Wanda, are you, the CDC or Danielle, I mean, you're the official data folks. And so I'm wondering, or if the academies, I'm just, is this something that's on anybody's radar? That's what I'm asking.
I see Paul Jarris had raised his hand visually, not just on electronically. Paul, do you have some comment?
Yeah, so interesting thing to learn as I've been working with MITRE, which is an organization that's historically engineering, software engineers and others. And so we have whole teams that do this, that monitor social media around different topics and for lots of different agencies. As you can imagine, intelligence agencies, others are very interested, but we also have a team monitoring around COVID-19. So you may know we've released this software program to help public health agencies monitor people, find contacts and monitor people in isolation and quarantine. And unfortunately, it's just a fact of life in public health now that you need to monitor the social media for mis and disinformation with a public health campaign. And so we have teams doing that, and we get daily reports, and we've already had threats on our lives from people that appear to be survivalists, white nationalists, and the local health departments and the law enforcement potential threats. So there is technology to do this, and again, unfortunately, it is now part of public health or anything else. I think we were picked up in Breitbart, and that's when things took off for us.
Right. And Paul, thank you for that, because local public leaders, like even in Omaha, Nebraska, among others, you know, those who are standing out and speaking for the work that needs to happen around COVID-19, and particularly the most vulnerable, are now receiving death threats as well. And so it is not a light matter, and I would encourage us, if we're going to be cutting edge as SACIM, to build off of those assets that, Paul, that you're bringing forth and take it seriously.
All right, I'm going to take one more comment. I'm going to take one more comment before we get to the next item on the agenda. Belinda.
Yes, I know one of the things that we have spent some time talking about more recently in our state is around with our historically marginalized populations, and specifically the Latinx population, because a percentage are undocumented, and their fear of coming in for care, treatment, testing, or anything, and wondering have there been any conversations or any considerations during this pandemic? Can there be conversations, I guess, with ICE, because they're basically concerned about they're not coming in for testing, they're not going to get treated because of the fear that they're going to be deported. But we also know that many of them are of reproductive age, and you're dealing with pregnant women who are going to have children that are going to be citizens. So it's almost like we're missing this opportunity because we're so busy trying to just get rid of a population of people. So we're trying to figure it out in our own state, but wonder, has ICE been given any additional guidance? Or do we even know what they've been told? Is it status quo, even though we're trying to increase our testing and our contact tracing? So that's something to just kind of keep on the forefront as well. And I know Wanda mentioned, the recommendations that are coming out of the maternal mortality review committees around the state. But the maternal health innovation sites and the RMOM sites, the rural obstetrical management sites, they're also charged with developing in their communities statewide maternal health strategic plans. So they have task forces. So that may be another way to get some information about what is happening locally.
I know Paul Wise has been actively on the border issues, and he's not here right now because he had to go to court or go to work with the federal courts on a lot of these immigration issues. And so we may want to tap into his expertise to answer some of your questions, Linda. All right, we're going to come. Did somebody have a comment?
I was just going to say, Ed, that the unfortunate thing, Belinda, is who is it that could give you a reassurance that you would count on? It's almost an unanswerable question.
I know.
All right, so if you have other thoughts, save them, because we will have time at the end of our meeting tomorrow to, again, carry on this conversation and come up with some other issues and then recommendations. And then we'll also, some of the questions that have come up will be carried forward into the work groups that you're going to be working on in the latter part of today. But I do want to take time now to go back and review the letter that I sent to the HHS Secretary back in March and have some discussion about those recommendations. When we put this together, COVID had just came on board. There were lots of unanswered questions. There still are, but it was high visibility, and there was some concern about what hospitals were doing and how they could manage the influx of patients and what would happen to pregnant women and infants. And we looked at what ACOG was doing and what AAP was doing and the Society for Fetal and Maternal Medicine was doing, and came up with these recommendations after conversations with the group. Because it was not an official recommendation, because we have to, in order to do an official recommendation from SACIM, we have to have a publicized meeting and have a vote, and so that that it's visible to the general public. So it was an unofficial recommendation. So I'm bringing it back now because a lot has changed since March, but a lot continues to be the same. And so I want to review these recommendations and get a consensus from the group of what we can officially move towards to the Secretary. And I hope you have in front of you the 9 recommendations. Let me just, even if you don't, stand up hospital linked, non-hospital based labor and delivery units, and expand the capacity of freestanding birth centers. Expand the use of licensed or certified midwives in these centers to allow them to practice to the full extent of their certification. Expand access to telehealth in a broadly defined. Support community-based postpartum and newborn care. Support broad financing, including Medicaid for telehealth. Permit states to continue eligibility for Medicaid for the full year after delivery. Expand the use of federal financing for home visiting. Provide professional liability insurance, and then expand data and surveillance systems. So I'm, given those, and you've had it, 3 months to think about those. Are there concerns about any of those that are they no longer applicable, or are there new ones that we should add to the mix? Magda.
I would just piggyback off on the very, sorry about the background here. Is there the possibility in your first bullet point, Ed, given the conversations that we've just had, to augment, this is a simpler one, to specifically cite undocumented?
Okay.
And to take a look at the special populations that have been mentioned today. We don't need to go into detail, but I think that if it's not explicit, it's not there. And so the first would be to make sure that the populations of greatest marginalization or risk or vulnerability are called out in the first bullet point.
Okay. So, yeah, okay. So there's the overall cover letter raised a lot of issues, but the specific recommendations, I wonder if we need to put that into any of the specific recommendations. Lisa? I'm not hearing from anybody.
So, Ed, were you asking if Magda's suggestion could just be a standalone recommendation?
Well, I'm wondering. So the letter that the letter that I wrote covered it gave a context for it all and made some assumptions.
Right.
And it came down to 9 specific recommendations. Now we can redo the letter and make sure that it broadens the context a little bit more, and we can make those undocumented as part of specifically in that context. But should we actually put it in any of the specific recommendations if they be taken out? That was my question.
Yeah, my point here is that given what we heard this morning, and given the explicit nature of racism exposed and amplified by COVID, I would be open, without wordsmithing, to look at how the therefores, yes, put it up front, but more broadly, it protects all pregnant women. There's just something about our opportunity around COVID, which this was written prior to the break open of the nation in racial unrest. And I would be curious if the Equity Committee could help us with that, or more broadly, but I'd sure like a number 10, something that calls it out, because it's there and it feels like it's glaringly missing. So I gave the documented as an example up front, but I am piggybacking off of Janelle's that if it's not in there, and the question of what would be the specific recommendation, or I'd have to give that some thought. But I just feel like, pay particular attention at this time of the exposure of racism.
Yeah, I agree with that.
And I want it to be actionable. It's got to be actionable. I get that.
Yeah.
But right now it's not there at all, and this was written prior to May 25th.
Yeah.
For things that were there long before May 25th.
So what I would recommend is that in the Equity Committee work group, maybe come up with some recommendations that you can bring back to this group so we can add, if people agree, add that to our list of 9 recommendations. Lisa?
Yes.
Not hearing you.
Yeah.
Okay, let's go to Jeannie.
Okay, thank you. I am concerned about the wording in protect pregnant women and infants from harm, the stand-up hospital length, non-hospital-based labor and delivery units, and expand the capacity of existing freestanding birth centers. To me, that you're looking at a long-term, not an immediate possible solution, and I say possible because, again, being part of the data group, I want to look at that. But what I clearly heard from patients and from the clinicians providing labor and delivery care is the safety for all parts. And safety meaning if you're in not a standalone, you're in a hospital-based labor and delivery unit, and the hospital takes the personal protective equipment over to the ICU because that's the greatest need. It was the autonomy of a labor and delivery unit. You can have autonomy and still be in the entire hospital. So being able to be autonomous and place labor and delivery as a distinct and important entity, to me, is the most important and clear statement that we need to make. We've got existing labor and delivery units. We've got existing birth center units. So how do we make sure that the patient's perception is that they are safe? And I think addressing that, not saying that we need to build more. I mean, look at what it takes to build any other units. It's an extremely costly and very unlikely to happen in the near future. But you can address the autonomy of a labor and delivery unit so that they function and can assure patients that they will receive a safe environment, that the protection is at first and foremost. And I don't think this captures that.
So your concern is the stand-up part and the non-hospital-based part? I'm not quite sure that I understand all of it.
I would call it labor and delivery. That any labor and delivery unit has its autonomy. Because to me, I'm seeing this is we're going to expand the capacity of existing freestanding birthing centers. I don't know that that needs to happen in an immediate response around COVID if this is what we're addressing. Rather, you have existing labor and delivery units. You want them to be as safe as possible for the patients that are delivering there. You want patients' perception in the community to be that they are a very safe location to go. And making sure that the hospital is able to say, this is how we achieved autonomy and this is what we're doing is absolutely critical.
So I heard from Steve Calvin that there is an increasing demand for birthing in birth centers, and so that there's some capacity issues related to that because of just the number of providers that they have. So it does sound like there is a demand for currently during this crisis for that kind of service. Steve, is that what you're sensing?
I about, we should recraft the language. I think the language in the letter you wrote for directed agency, it was math, that's the way I'd heard it described, math set up, maternity. We know we're not there. I would suggest putting language in that just says that mothers should be given the option for care in all accredited birthing environments that are available, and that their wishes are respected. What we're getting is just that the patients that come are saying, I feel like I'm going to the hospital and I'm going to be told it may change like tomorrow, where not only can you not have a doula, you may not have your partner with you. I mean, that sort of thing. So I agree with Jeannie pushing towards whether it's autonomy for those sorts of things, but just respecting the wishes of mothers and what they're looking for. Does that make sense, Jeannie?
Yeah, and I think we can all look back. I mean, I'm in one of the physician mothers groups and the OB moms groups, and I'm speaking every day with physicians who are moms taking care of moms and listening to their vulnerability and their fears too. So you've got fear on both sides, and this is a situation unlike anything that we've ever had. So making sure that we have created a safe environment for the healthcare providers and for the patients, because that's what they both want to hear. So whether it was the PPE that they couldn't get access to an N95, they're on labor and delivery. You only need N95s for for an ICU intubation or something like that. So I think those are the issues that you're hearing both from the clinicians and from the patients. So you wanted a broader description of circumstances and not just saying, I think that was the wording, pull it up again, expand the capacity of existing freestanding birth centers. I don't think that's the solution. I think that's one element of the solution, but we've got hospitals that have capacity. How do we make a patient's perception that those hospitals are safe?
So could you and Steve work on some wording for that, you know, with the work group, Steve's work group, and so that we can, you know, again, and then email it to me later on tonight so that I can see it and we can bring it back to the group?
Okay, and Lisa, you might have some, Lisa, you might have some suggestions for all the scenarios that came through ACOG. I'm seeing just probably a fraction of what you all saw at ACOG in the groups that I'm speaking with.
Mm-hmm. All right. All right, so if we could get, you know, if Steve and Jeannie could work on the wording for that, we can, you know, craft that. How about any of the other 8 points that were there? Any concerns with any of them? Magda raises her finger and her hand.
I heard this morning clearly, and again, it's like we're getting a new snapshot on our refrigerator because we're now 3 months into, or 2.5 months past when this was done. So thank you for the opportunity. On number 3, I think we can be more rigorous. I think it stands, but it's more than access to telehealth. I think we need to explicitly mention the combination of sustained, it's not just expand, but it's expand and sustain access via reliable broadband. And I think the broadband notion has been coming up again and again. It's not that people either they don't have broadband or they might have one screen at home. And at one screen, that screen's being shared with mom's doctor visit or doula visit, and kids being homeschooled or at least at home for school. So there's, I've been watching the internet companies, you know, Verizon and others, give these special, we're expanding your broadband, we're expanding, you know, but the value is that's short term and that's going to go away. And so I want to encourage us to put the language of expand and sustained access to telehealth to include access to reliable broadband and sufficient, you know, hardware at home. I don't have the right word exactly. Too, because if I'll leave it at that. Does that resonate for anyone else? I just think if it's not in there, it can't be implicit, and we've been hearing about it and hearing about it this morning.
All right. That one is simple enough that I can add that to that wording. I agree with you on that. So we don't need the work group to work on the wording for that one. Good. Thanks, Magda.
And
Paul.
Yep. So, you know, broadband is and telehealth is important, but I think it's also important to consider it in the context of the whole health system in a community, because it actually can have some very detrimental effects potentially. For example, if you had a telehealth come in and started picking up lots of patients, and let's say there's only one OB and one nurse practitioner in town, and they're losing that business, they are losing the income to support the practice. Then on top of it, when one of those patients needs to be seen, the telehealth provider can't see them. They're the ones that have to come in the middle light to see them. And so, you know, there's potential here to really destabilize. Or if the telehealth means that people are, high-risk people are being managed in that community, which is good, and an emergency happens, they may go into an ER, and it's an ER doc who does the delivery or whatever. So we looked at the whole system to make sure that the remaining docs in the community can handle what's coming at them. So that's all I'm saying is it's, you know, in and of itself, telehealth is not a panacea. It has to be part of a comprehensive system of access for women in a community. And in those unfortunate cases where it means it skims patients off the community hospital so they no longer can support their OB unit, then it's really very harmful. So just another perspective.
No, I think that's a great comment. This is Jeannie again. Sorry, I interrupted.
That's fine.
I was just going to say, if you want to use an example for a group that's really successfully done telehealth, it's the Kaiser Permanente. We've been doing telehealth there for, trying to guess, 8 years or longer. I know they went into overdrive with COVID, but the video visits were an element. So being able to speak with some of the leadership there on what it took to integrate, and I know it's a preventive health organization, but they certainly have a lot of tips that people can learn from.
Right. Yeah, and Paul, so I think that's great. What Magda said about the sustained and reliable and broadband and hardware, and in the context of the broader healthcare community or broader healthcare system, I think would be a good point to make. So we can do that. I think that's a good addition. Steve, and then Janelle.
Yeah, actually, I got a question was answered. I'm just working on something to maybe think about from the letter suggest.
Okay. Janelle.
All right. One of the things that I thought, so yes, Jeannie was talking about Kaiser using telehealth, and definitely since March we've had, it's something like a 120% increase of using of our telehealth, of telephone and video appointments, and definitely with the government, Medicaid covering Medicare and Medicaid covering video visits. That's certainly helped support telehealth medicine. And I was just wondering if, maybe there are avenues for the institution, wherever the patient is getting their care from, of being able to somewhat tether their device to that institution that allows them access to be able to participate in video health, or so that they are not using their data usage for that video visit or something. I'm going to ask, if we go back to point number 2, expand the use of licensed and or certified midwives. I believe with a prior discussion with a past participant and who was invited to come talk with Health Equity, the issue of licensed versus certified midwives was brought up, and the states have a system for certified midwives, and so the issue of licensed midwives is only used in California. So only my special state that I live in has that special term, and licensed midwife, that term does not have certain education tied to it. But if we just can take out licensed midwife and just use certified midwives, I guess that would be the language that we should probably use in this recommendation.
Anybody have a problem with that?
That makes sense.
Okay, that's easy. All right. All right. Any other recommendations that people want to comment on?
I just wanted to. This is Wanda. Can you hear me?
Yes.
So I just wanted to comment on. I know that it's important that we think about the the maternity wards and our labor wards as distinct and in need of support during, particularly during pandemics. But I think there is a degree of interdependence, particularly in terms of assessing surge capacity, that I don't want it to appear that it's an isolated, distinct island in and of itself. And I think that's very important because there's a lot of support that is shared in a labor and delivery unit, whether it's, laboratory support, respiratory therapy and support, transfer to the ICU as the patient gets worse. The whole design in terms of surge capacity, we end up, say, for example, closing the pediatrics ward so that there's an opportunity to maybe bring in other patients, and then how can labor and delivery help with that? So I just don't want to imply that they're an entity in and of themselves. I was trying to say it earlier, but I was having some technical difficulties.
Yeah. Yeah, I got a sense that, Jeannie, I think that's what you were also trying to link it as part of the system, and that was part of what I'm hoping will come out of the new recommendation.
I think especially rural
hospitals. As a system. Yeah, I mean, I think the emergency room is perceived for what it is, an emergency setting. But you're right, Wanda, you see that surge happen into and out of labor and delivery units and labor and delivery personnel, which the more that surge impacts the flow, the more the perception is that any woman who's just coming in, just quote, coming in to deliver a baby is no longer safe.
Right, and I mean, granted, there's so much variation that, it's really hard to say, but I mean, I know some hospitals are trying to, for example, avoid the emergency room altogether when a pregnant woman comes in so that she's not exposed, right?
Exactly.
So, those are the kinds of things where we just need to continue to consider, but the support is very important.
Yeah.
In rural hospitals, of course, the nurses often will shift back and forth between med-surg, ER, and labor and delivery. So it really does have to be looked at as a unit.
This is just something that I've seen, in the field, working clinically. But when we were going through, an increase of COVID cases within the hospitals I work at, there's something to be said for that one-to-one care that might happen more so in a birth center versus in a hospital setting. The nurses who are caring for women, whether or not she was a PUI, whether she was highly suspicious for COVID or not, really were not engaging with our women. There was really not a lot of one-to-one care happening for that woman, and then taken into account that there was a period of time where women were told they could not have a support partner at all. So just thinking as we move forward and thinking of, yes, hospital as a unit, as a place, like if someone is very sick, or, it can be a very special place, a very safe place for women and their infants, but also for women who are otherwise healthy or low risk, and definitely birth centers appropriately have a long list of factors that would have a woman transfer out of their care. Like they would not be in their care in the birth center. And so if women are making the list and they're very low risk, and if they are choosing to use a delivery out of a hospital, such as a birth center, with seasoned and experienced providers, expanding that mode of care might be necessary, might be important for our community.
All right, Magda, you had a comment.
This morning we heard Joya talk about a reproductive justice framework, and it's a more general comment. I so appreciate the pragmatism and strategy about focusing on do no harm to pregnant women and infants. And I'm also mindful of what we may be hearing around limited or more constrained access to the full range of FDA-approved contraceptive methods and devices, and in the context of preconception health. And I just want to ask you, as my colleagues, whether these recommendations, boundaried by pregnancy and newborns, specific in the short run to addressing maternal mortality and infant mortality, whether there's any opportunity or appetite to even explore the interconception or preconception period as we think about the potential impact of COVID-19. So it's more of a framework question before I get to the specific of what would be the recommendation, and I just want to know if there's any interest in exploring assuring access to not just prenatal care or pregnancy-related, but also contraception or family planning.
So what I'm thinking is that these recommendations were very specific related to the healthcare system relative to COVID. And so I'd like to get some consensus on this. And then tomorrow, then say, in addition to these, that really came out from that letter and that we now have verified, there are some other issues that we would like to, recommendations that we would like to make to you, both in the context of COVID and in the context of everything else that's going on. And I would see that would be where we may come up with another recommendation to, add on, if we agree to add on to this list, or have another sort of list separate from this list of COVID-related things.
I am absolutely at ease with that. We remiss, given what we know about life course and given that we know about upstream, in the spirit of Dr. Warren's comments this morning, and what we know about before, between, and beyond pregnancy, to not address it. So if it can be brought up again intentionally tomorrow afternoon, that would be acceptable to me. I just don't want to remain silent on it.
No, that's fine. Belinda.
No, I was trying to figure that same thing out, Magda, and I kept looking at point somewhere between 6 and 7. I mean, on 6, we talk about continuing Medicaid, which could help with addressing, but we don't actually say for a year. I was wondering, do we mean to say for a year? We actually say for the duration of the emergency. We say the infant is already covered for a year, but we don't say that for the woman, because it could be an opportunity to address some chronic health conditions that will put her at greater risk for being infected with COVID. So I was wondering, could we put something there that will fall more in a conception language? And we talk about the 4th trimester, but we only talk about it for home visiting. We don't talk about it in general. And we picked that up in number 7. So I'm fine with waiting till tomorrow, but those were the 2 areas that I've been looking at, trying to figure out if there's a way to get some interconception language there, especially if we connect it around addressing chronic health conditions.
Chronic disease. That's a great point.
All right. Yeah. So what I would like to do is I would like to this afternoon, in the 10 minutes that we have left, actually get an agreement that if we change number 1, which to really focus more on the safety and of those units and the integration of the healthcare system, expand number 3 to really talk about sustaining and broadband in the context, adding another recommendation related to equity, particularly for undocumented. And then, get a general agreement that we're not on those. Then we can do some other wording during the evening to add on to some of these recommendations, so that we can go back to specific ones. Like we would come back to number 1 again tomorrow and approve the language that's there, and approve the number 10 recommendation that's there. So that's what I'd sort of like to do. And if we can do things right now, adding Magda's points and Belinda's points to those, if you could give me the wording for those, we could do that right now. Or we could just add those as an add-on to our general recommendations from a SACIM meeting later on tomorrow afternoon.
This is Tara. Can you hear me now?
Yes.
Oh, thank God. Okay. I don't have my video up because I don't know, maybe they can't do both at the same time. One thing that I just wanted to mention is I think, there's been a lot of talk about ethnic disparities in right now with COVID. And I've definitely seen some reports, a lot of reports and data about that. But one thing I am seeing that's lacking is specific data about ethnic disparities in pregnant women. And so I think, I've been seeing some specific papers that have come out looking at the UK. I mean, there was a recent study that just came out by Knight et al. In the UK showing that for maternal mortality, 5 out of 427 cases resulted in maternal death. And then they showed that there was racial disparity, but we just don't have enough U.S. data. And I know that that's in there. I know that there's been a lot of talk today about racial disparity, and I agree that that is definitely happening, but I think we absolutely need to focus on getting that data getting publishable data. And so I know that our ninth, getting back to the recommendations, I think that falls right into recommendation 9. So I know we're expanding data and surveillance systems, but I think we need some hardcore facts to stand behind some of the, behind everything that's been said today. And I know that the CDC, it sounds like, is working on that, but I'm just not seeing it in the published literature.
So this is Wanda. Are you talking about in the context of COVID or more broadly?
I'm talking in the context of COVID specifically. So I've been doing a lot of research on maternal mortality and infant mortality with COVID. And I know that there have been reported ethnic disparities in incidence and outcomes, especially in the UK. I'm just not seeing a lot of, and if people have those reports, I'd love for them to send them to me. And so I just think we need to make sure that these registries that are being established, there's a lot of registries internationally and nationally. I can only assume that they are collecting race data, but I just think it needs to be more clear. Where is that data going to come from and who's doing it?
So if I can interject here, there are a number of registries that are taking place. Very few of them have published any of the information. Priority has been meeting every 2 weeks. They are out of UC San Francisco and UCLA. The Priority group is trying to harmonize the data collection so that everybody collects at least a certain baseline, and they've shared that harmonization. If you go to Priority, they've got it there. And yes, race is one element of it, but we've got Colombia, Chile, Argentina, Kenya. We've got a number of international sites. The COVID registry out of the UK is linking with all this. We're trying to harmonize the data, and certainly race is one element of all the bits that are being collected. Dr. Leslie Regan, who's the past president of the Royal College, is going to oversee some of the harmonization for that. So if you want to keep linked with me, I can let you know what's going on.
Okay, that would be great. Thank you so much.
Yeah.
I do think those concerns are actually embedded in number 9, so I do think that covers those kinds of things. So I'm going to recommend, walk through that I get a sense of general agreement with most of these things. However, if we rewrite number 1 with based on what Jeannie Connery was bringing up, so we'll redo that one. We will take out licensed and/or in the second one. We will, in number 3, we will talk about sustaining and using reliable broadband in the context of the healthcare system. We will do 4 and 5. And number 6, we may want to do a little bit of tweaking in terms of adding more specificity and clarity around Medicaid and intraconception care. Number 8 and number 9 would be the same generally, and then we would add a 10th one related to equity that the Equity Committee work group would work on. With that, would people be in agreement with that summary, and that we could say, yes, we agree with that those things, knowing that we'll come back and officially approve number 1 and a new number, a rewritten number 1 and a new number 10. Magda, I see you got a thumbs up. Anybody?
I'm just saying, I think that you've captured the right things to do to take us to the next draft. I think there is a sense of timeliness and urgency to have something by the, ready to go. And so I think that by the time we get to the end of the meeting, we should be ready to have something that can be more tangible and a product that we can stand behind.
Okay. All right. So I would actually like an approval to say this is what we want. We're in sort of agreement at this point, knowing that we'll come back and finalize the vote tomorrow.
Ed, I'm sorry to add something at the last minute, but I'm wondering, we're talking about monitoring pregnancies during COVID, but the same database could subsequently be used for monitoring children in the event there were an effect of COVID on children in some capacity in the long term.
Mm-hmm.
And again, what I'm seeing is that we have this very specifically focused set of recommendations, and when we write the letter to the secretary, we can say, in addition, these are some additional things that we could add on, and that would be one, that some of these things can be used for children, that some of these things can be used for, whatever, and any other recommendations. But I would like to move this set of recommendations forward as best we can. All right, I don't see any. If anybody disagrees, raise your hand with moving ahead with the gap. And I don't see anybody's hand raised. So, all right, so if Janelle, if your group could develop something in your work group and get it to me by email tonight, and Steve, in your work group, do something related to that first recommendation along with Jeannie, because I'm not sure, Jeannie, which work group you're in. Can't be in two at the same time at this point. And also get that to me, then we can put it together and share it with the group. And Belinda, if you had any recommendations that you would like to make on number 6 or 7 to clarify that, that would also be helpful. All right, moving on. Thank you for all your work. This is the kind of thing where I'm hoping that we as a committee can say, here is a unique opportunity. Something is happening right now. Let's jump on it and make some recommendations based on the best ability that we have with the best information that we have, and not spend 3 years, trying to get it to the most polished state ever. By that time, it's beyond useful. Okay. I'm going to turn it over now to Lee to talk about the PREMIE Act. And I'm also going to tell you, we're not going to take a break because I think the PREMIE Act conversation may not be that long. You'll talk a little bit about the praxis, and then we'll go into the breakout groups. So I don't think we need to take a 15-minute break. At least I'm sensing that we don't, because I'd like to move this forward. And if you do need to take a break, just turn off your camera and come back later. And so the PREMIE Act, I put it on the agenda because this is an area where I'm confused in terms of what SACIM's role is, and whether or not we function as the committee overseeing the PREMIE Act. So I want Lee to sort of clarify where we are so we know what our responsibilities are. And I know that MCHB has been working on a report that might meet some of the requirements, but I'll turn it over to Lee to walk us through that.
Okay. Can you all hear me?
Yes.
Yes. Okay. So I'm gonna do this without props because I wasn't sure exactly the degree to which we were gonna go into details or the amount of information that you all would be interested in having on this topic, but we can provide more to you. So this advisory committee has been in existence for quite some time, and it actually predates the PREMIE Act. We've had a series of conversations both internally at the department level and with Congress about the role of this committee as it relates to what has been proposed and has been authorized in the PREMIE Act, and the best use of the resources that we have currently invested in these efforts, and how we sort of accommodate the intent of the legislation with the appropriation situation. So I'm going to speak from HRSA's perspective, knowing that CDC also has a branch of the PREMIE Act that has not been funded, and NIH also has work that is done. PREMIE is actually quite a large piece of legislation. The PREMIE Act calls for an advisory committee, and although the PREMIE Act was authorized, it has never received an appropriation. So there has been some debate back and forth as to the degree to which the agencies that are tasked with duties or assigned with duties under the PREMIE Act are then responsible for fulfilling those duties and responsibilities. So given the fact that there was no appropriation, we are not obliged to, although it is the intent of the agencies that have responsibilities or charges similar to work that's outlined in the PREMIE Act, to continue on with the work that they have been doing. So our response back to Congress when they have inquired to us what we are doing to fulfill those requirements is to say that we have had a long-standing committee that has been charged with working on infant mortality, and as you know, in the new PREMIE Act, it does expand that work into maternal health and maternal mortality in a way that it hadn't been before. So we have tried to incorporate that piece into this committee as well as a clear charge in response to the intent of Congress on that point. However, and Paul, I'm jealous, you have some dumbbells there. No, keep doing it.
Sorry, I was trying to hide
it. So anyway, we have been pursuing this committee with the idea of trying to speak to Congress about the fact that because the committee exists, there is no need to create a redundant committee. That the intent is that this committee, that it has been in existence, will fulfill that requirement. That said, the legislation has also called for a report back to Congress on the committee's deliberations and their recommendations. We have not pursued completing that report because, as I said, since there has not been an authorization for such a report, we are not bound, and in the tracking systems that the department has put together for responding back to reports to Congress, that is not listed in one of our requirements, absent the appropriation. We are mindful of that balancing act and the desire to try to fulfill, but also not to present the case that we can do this work without the needed appropriation to make that happen in an effective manner. We are pursuing, as we move forward, the development of a report that would look at three different components. One would be a summary of what the work is that's going on in the deliberations that the advisory committee is considering and discussing. Two would be any research or data activities that you are looking into or would like for us to pursue as a summary of the types of things that you're looking into. And then third would be a summary and report out of what the recommendations are that the committee has been discussing and where you've come out on those issues. That is in the development here. We have not gotten very far in the process of actually executing that. It is planned for the next award of the logistics activities of this contract. If it goes forward and we have the resources to make that happen, we will then be able to work with you on the development of that report. So we are in this unusual balancing act of trying to live within the spirit of the legislation while arguing that resources cannot be taken away from other activities that the agency is funding in order to underwrite the efforts of what Congress has said. So I know there was some back and forth a few months ago about whether we were meeting the intent of the legislation with a report or not. And when Ed and I had these conversations, he felt it would be important to clarify. If you have any questions, I'm happy to address them with you, and we can go from there.
Thank you, Lee. Do you have any suggestions on what we as the SACIM committee should be doing related to the PREMIE Act right now? Or do we just sort of wait and see what this report starts to look like as you start working on it and then give input on those three different areas and then come back and review it at a later date? Or do you have other recommendations for us as a committee?
My guidance to you would be to look at the legislation, the way the legislation is worded. If you have any recommendations, either in affirmation of what the legislation says or changes that you think would be warranted as experts in the field, I would encourage you to acknowledge that, and I would encourage you to consider the situation as it exists, that there is an authorization without an appropriation, and what limitations that may cause you and the agencies in administering or following through with that intent. If there are recommendations that you want to make in that area, by all means, you are empowered as an advisory committee to the Secretary to make those recommendations. It is within the Secretary's purview to deliver them to Congress if he chooses to do so. But we are relying on you as experts at arm's length from the agencies to say what you believe is most important.
All right. So that our general work, like the work that we're doing with the 3 work groups, and as they report out what their preliminary recommendations are or the work that they're going to be doing, can all be fed into, you know, what the Bureau is thinking in terms of what its responsibility is to reporting this out, and particularly around data and research and around the current work of SACIM. This would, you know, as we monitor, as the chair can sort of tell you, this is what we're doing, this is how we're thinking, and this is the stuff that, the recommendations that we're working towards.
Correct. I do want to point out that this report that we are generating, because there is no appropriation, is not a report to the Secretary as such, because this is a report that HRSA is funding in working with you to come back to HRSA, because there is no appropriation that makes that charge of you. So I would suggest not to rely on this report necessarily to be the vehicle for the next 6 months to a year on any program or policy recommendations that you intend to make, because that report is going to take some time to get awarded, be generated, and then go, you know, be received by the agency. If you have particular recommendations, so you've got your letter right now that you're working on and making recommendations. If there are other recommendations that you intend to make, vote on them, make your decision, send them to the agency, and those recommendations will be transmitted to the Secretary. This report is not intended to be the vehicle saying, here is what the committee is stating we want right now.
Okay. So basically, we just carry on with the work as we've done, and the PREMI Act is, to me, sounds somewhat irrelevant to the work that we're doing. I mean, we're already doing the work, and we've been doing the work for 31 years or so, and then this wouldn't really change how we do our work. It'll meet those needs at some point in time.
It is relevant in that it gives you the added support of saying this is in keeping with the intent of Congress. So, however, it doesn't change your charge at this point in any way unless the agency chooses to do that. I do think that, in my own opinion, there are a lot of things that are called out in the PREMI Act that are valuable, that actually mirror some of the points that have been made about the importance of data, the importance of reaching out to the community, and some of those programs that are built out in the PREMI Act that you all are calling for funding or for additional emphasis. So there is some alignment with what it sounds like the PREMI Act is trying to do. I apologize for going dark on you. It appears that my neighborhood has lost power. So I'm talking to you over phone, but I can't see any of your responses. So also, I think it's worthwhile to allow CDC, Dr. Barfield, if you have any comments at this point and want to weigh in, please feel free to.
Yes, hi. Yes, it's correct that it isn't an appropriated funding for the PREMI Act. Our division has a subline from Safe Motherhood, and we have about $2 million in funding that's being used for that. But it isn't an appropriated amount, and we'll be providing information in the report along with HRSA and NIH.
All right, any other questions or comments from the committee? I see Magda's and Belinda's names up there. I don't know if that's from previous or not. Anybody else have any questions? All right. Well, then, Lee, you just clarified that completely, and I can still see you, so you may not be able to see us, but I can see you.
Well, now I can. Thank you. Yes.
Very good. All right. Thank you much. All right. Now we're into the home stretch for today. We're going to be looking at the work group praxis and then breaking up into work groups. So that we started working on the work group charters. Since it was getting confusing at what the charter was. It's the SACIM charter, is it a different charter? So we changed the name to praxis. So everybody has their own praxis, which is just a fancy term for charter, I think, and the work that you do. and I was hoping that each of the groups could come up with a praxis to outline the purpose and some of the methodology or the outputs that they want. And then I wanted to really kind of sort of get everybody's input so that we're sort of in agreement, so we know what the work groups are doing, or we all sort of understand and be supportive of it. And then that's where a lot of the work can be done for the committee as a whole through these work groups. So you've gotten I think you've gotten drafts of the 3 praxis. And I'm going to have each one of the chairs of those work groups give you a little update on their praxis, and then we can have some conversation to see if there's anything else that people want to add to the purpose statements in particular, and before we break up into the work groups and do the work that fulfills the praxis goals. So let's start with Steve.
Okay. Well, I actually took my cues in many ways from what Magda put together and Janelle as well. So it's basically just focusing. I mean, all of our work, I think, dovetails. Of course, the equity and disparities, very direct focus. And the data is probably going to be covered by all 3 of our groups. But from our perspective in the work group on quality and access, it was to identify what are high-quality options for care, all the way from the traditional system with many of the safety bundles and things to kind of a more expansive look at honoring mothers' choices and what they want for their birth experience. So, I don't know, that's kind of just the focus then is on identifying high-quality care and then trying to look at what are the access issues, what are the barriers. Sometimes they're regulatory, sometimes they're almost interpersonal, social. On many occasions, they're based on the financing. And I think that's why tomorrow I'm looking forward to a presentation that folks from the Institute for Medicaid Innovation are going to be giving to the whole group. So that's pretty much the summary of our focus, and we're doing this in a collaborative way and utilizing everybody's input.
All right. So who from so we each of the SACIM members, I think almost everybody is on a work group, but we do have the ex officio members. Are there any ex officio members that you'd like to recruit for your work group before we start then going out for people beyond the members and the ex officio members?
Yeah, I think the ex officio.
Any kind of expertise you'd like in particular?
Sure. Well, the ex officio member that I haven't seen or heard from her, but Suzanne England is an advanced practice nurse, and she's the ex officio member from the Indian Health Service. So she has a really great focus on rural health and then the particular challenges of the Native community. So I haven't heard from her. And then we have from a committee, Tara and Colleen, neonatal perspective, and Tara representing a research perspective too. So that's who we have so far. That we have a couple of outside folks who are joining us as well, and I'm grateful for that.
All right. So If you need, go out and recruit. Get all the horsepower you can. Magda, how about the Data and Research for Action group?
Thanks. I did throw up a couple of slides. I don't know if they're available right now, but I'm happy to talk about them if they're not. Also on page 39 of the 406-page briefing book, in case you're looking for where it is, you will find our draft practice, and want to take an opportunity to thank the core members of this work group for putting legs on this thing. So if you could, and I noticed that no matter how well you do your slides and we throw them up in Adobe, they're going to be corrupted a bit. So let's just all see this is messy and it's fine. If I could have the next slide, please, because I'm not sure I have the ability to advance it.
I did give you the ability to advance it if you'd like to do it yourself.
You did. Well, either way, I'm not sure. There's only three of them. Only three of them. So I want to acknowledge the who of this, specifically Jeannie Conroy and Janelle Palacios working with us, with Ed and me as the four core members of SACIM. And special thanks to Danielle, Ili, and Cheryl Broussard for joining us from NCHS and CDC, Birth Defects Division, to round up some of our initial core, set the foundations members of the ex officio. And then today we also will be joined by a couple of additional outside folks who are bringing in local public health perspective and certified nurse midwife perspective and academe, as well as Wanda Barfield will be joining us as well, bringing in that robust other parts of CDC. So if you're listening in, we got a pitch for you to both build out that number 9 of the recommendations that you've been hearing about, as well as try to articulate some of the issues and gaps and opportunities specific to COVID-19. We've done our brainstorming. We've also developed the praxis, which I'm going to talk about just for a minute right now. And specifically, if you could go to the next slide, because I'm not quite sure that I don't want to break it, that'd be helpful. You know, what we see the value of this particular working group for SACIM is to make sure that our deliberations and our decision-making that produces strategic policy recommendations for preventing maternal infant mortality and promoting health equity are based on available evidence and science that are credible and reliable and timely. So I really appreciated the question that Tara Lee was asking earlier, like, where are the data? Because we live in different worlds, and it's always making sure that it's substantive and not opinion or ideology, that we are an evidence and science-based group working together. Within that, we have identified a series of overarching goals specifically to COVID and pandemic, and then more general. And yes, we will look to try to identify, access, and use both quantitative and qualitative data and research to do our work across sectors, so housing, food security, child care, economic development, justice, education, business. We see ourselves as the interface for data and research with those ex officio members who are coming in from housing and urban development and coming in from ACF and elsewhere. So we can be a bridge through data and research. We want to make sure we're identifying gaps and deficiencies in the data, but also how do we build capacity? That has come up this morning as well in terms of recommendations also around training, as well as strengthening and revolutionizing, in some cases, systems that make the data sing for us. We also want to make sure that we're elevating the research results from a variety of voices, and particularly community voices, to illustrate our findings, knowing, as Bill Sappenfield always say, that behind every number is a person, a face, a story. Specific to pandemic, we're going to be applying that lens. And last, we want you to know that we are seeing this as an opportunity to advocate more broadly for a different 21st century surveillance and data systems, not anemic, not necessarily exactly as they have been, but in extraordinary times, extraordinary things may be possible, and particularly in terms of leveraging out the existing data systems and the more timely registries and other real-time data that are emerging in the face of COVID. So towards that end, if I could have the next slide, if you come to this particular session, you're going to have a consultation time with a series of questions that are going to drive our conversation specific to COVID around how well are existing and emergent data systems and sources informing us, and what are the gaps and deficiencies, and how can we work across sector, and what are the explicit recommendations now that can augment what we're putting in number 9. And in the next slide, we will be open to our ongoing question about how do we have amplified, robust, creative, innovative data systems aligned across sectors to prevent maternal and infant mortality overall. So the questions about major gaps and deficiencies, as well as emerging qualitative and quantitative data and research that we need to elevate up. Too much to handle in one breakout, but we wanted to say that these questions align with our goals, so the way we spend our time gets us the results we want to get as one leg of this three-legged stool. So come join us. If you don't know where to go and you're listening online, beyond all the folks of SACIM members, ex officios, if you're still there, we can really use your brilliance, insight, and hard questions. And that's what I got.
All right. Thank you, Magda. Good recruitment. Good recruitment.
A pitch.
So now,
a pitch.
Janelle and Belinda, health equity.
We can't hear you, Janelle, if you're speaking.
Okay. Better?
There you go.
Okay. Belinda and I have been are co-chairing the Health Equity Work Group, and we started with the premise that everyone has an equal and just opportunity to live their healthiest lives possible across generations. Our current group has 9 people, of which 4 are SACIM committee members, Paul Jarris, Belinda, and I, and Wendy. Representation from ACOG, ACNM, and New York City Midwives, and Wendy is the ex officio from the Office of Planning, Research, and Evaluation. We are still in the natal stages of creating health equity work group, and recently we just started working on, we've had a few drafts of our praxis. So this is our pitch to have you come join us during the breakout. Okay, next slide. Given what the presentations that we've had today, I believe the praxis will change a bit. We started with the purpose to promote common understanding, to identify gaps and generate plans and take actions utilizing health equity as a framework. This may expand given what we talked about today. We want to ensure that SACIM's considerations and policy recommendations are grounded by a shared understanding of and commitment to health equity. And we intend to work closely with data and research and access and quality to make sure that the recommendations are seamlessly incorporating health equity when needed. We also want to include the social determinants of health to address the needs and health improvement among women and infants across U.S. lands and territories. Next slide, please. We have a few goals. The first goal is to just discuss and promote the use of specific common terms grounding women and infants' health in their lived social circumstances. We did this by creating a racial justice informed lexicon that is part of the appendix to our praxis. It's a very long list, but a much needed list so that we can all be on the same page when we use certain terms. We want to advocate and discuss for discussion and planning and actions taken by SACIM, which addresses racism as a nationally public recognized health crisis. And a third goal at the moment is to ensure all immediate and longer-term recommendations made by SACIM that safeguard and protect maternal infant health during COVID pandemic includes health equity measures. And then what are the actions that we've taken? We've had 3 meetings to date, largely working on the praxis, and we've discussed COVID in relation to women's health, and then we provided a racial justice lexicon. So we are at this point in time where we would like to invite people to come speak their thoughts and suggestions regarding SACIM, how we can address health equity, what are the next steps, and we really want to have an action piece. Please go ahead. I can't remember if there's a next slide or not. It might be the end. Yes. So we would like your expertise in helping us develop the future. What have we missed? What are the steps that we need to take? We would ideally like to hear thoughts on how to engage communities, or which organizations or institutions are leading us in engaging communities, vulnerable communities and communities of color, to address health equity. Belinda, you're welcome to jump in and add any additional thoughts on what we would like to see as far as expertise in our discussion for the breakout.
No, I think you covered it, Janelle. I mean, we're wanting to have conversations around how to ensure equity is included in all of our work groups as well, and all of the work that we're doing. I think you did a great job covering it, so thanks.
All right. For the group as a whole, is there anything that you would like, if you're not on the specific committee, would you like to add to other committees, other work groups, any ideas that you might have at this point in time that you should expect that they could expand or include into their general purpose?
I think that one of the things that has come up that we cannot turn away from, that all groups should probably consider adopting social determinants of health as a driving or underlying force for the work, to contextualize the work that we're doing. So even though health equity is using social determinants of health to help guide recommendations or to guide our thinking in this, it definitely should be a part of each of the other groups as a foundation to consider, just basic access, access to prenatal care or delivery of care systems and modalities of care, as well as the research involved. And Magda, I believe the DRAW program already does this, but I think that we should keep it as a theme that all of us pay attention to across our work groups.
Good. All right, any other suggestions for different work groups? Magda.
I just want to thank, one of the things that I don't think you mentioned, Ed, is that you have served as the lead for a liaisons group, and just to acknowledge for those who are listening and not necessarily spending a lot of time with SACIM now, that we're not working in silos, as Janelle inferred, that you have convened Steve and Janelle and I to meet frequently with you and to promote the kind of cross-fertilization. And so I've heard what issues Steve's bringing up. The equity group passed on to the data group, Data and Research for Action group, what we call the DRAW group, their recommendations for data through the lens of equity. So I just want to commend the structure and how it's been set up so that we're not at cross purposes but more efficient, and how we're not only meeting within our groups and expanding out, but making sure that regular crosstalk is happening to fuel each other.
Thank you. Thank you for bringing that up, Magda. Yeah, this is a very functional group. We do interface quite frequently and share information, and it's been not very obvious in the development of the praxis that they're sort of there's an iterative process among the group. So I appreciate that. All right, anything else that people want to potentially add to the praxis? All right, if not, we're going to break into groups. So I do want to mention one thing. We got started a little bit late, and also we had a very large group of folks on the call or on this thing. So I didn't go through introductions because it would have taken a long time. But I think that this time when COVID is keeping us isolated and keeping us from visiting with each other in a personal way, and when we have lots of anger and frustration and anxiety and fear in our communities, that it's affecting all of us. It's not just affecting one group or another. I think all of us are in this. So I would ask you, as you get started in your groups, take a little time to introduce yourselves to each other in a way that is more meaningful. And and share what you want about what's going on in your heart, what's going on in your community, what's going on that is causing you angst, or what is giving you hope. So take a little bit of time, even though we couldn't do this in a large group. I think it's still important because we are working together. We need to be supportive of each other. We need to be partners in this in all sorts of ways. So what we'll do is we'll break up, and I think Morgan will figure out some way to get us into the right places. And I figured there'd be no way we'd be able to get you back again after these work groups. So once you're done with that, go have dinner or go have a glass of lemonade or go take a walk around at the beach or wherever you are. And then we'll see you as a group tomorrow morning at 11 o'clock Eastern Daylight Saving Time. All right, Morgan, what's the next step?
So for Janelle and Magda, if you can send me the names of your work group folks. Magda, I think I have yours because you emailed me earlier. But Janelle, you mentioned you have 9 work group members, and the list I had before the meeting only had, I think, 4. So I want to make sure that we have everybody that's supposed to be moving in to your Adobe room. For any members of the public who are not active participants of the work groups, you're welcome to call in and listen to them. The phone lines are to listen in on the work groups is on the agenda, as well as this next slide here. I'm going to move the cameras away so that we can see that. But yeah, so Janelle, if you can send me your list, that would be great. Magda as well, I think I have all your folks, but if you can send me that. And then Ed, for timing reasons and just to make sure that we have the transcriptionist on, we're running a little early. So if we're able to try to begin the work groups as close to 4:30 as possible, that would be great.
All right. Yeah, this is where people can take their breaks and go get a cup of coffee or go to the restroom, and then when you can get back together again at 4:30 to start, that would be great. All right, any questions from anybody?
Sounds good.
All right, and then so I will be working. I've gotten a little bit of input on this on the chat box on some of the recommendations for the COVID-19 recommendations of the Secretary. I'll work on those, but I'll look for any further input from Steve and Janelle, and then I will pull that together, and I'll try to get it out to you tonight or in the morning so that you can see it, and then we can vote on what we're going to go with that, how we're going to go with that. All right, have fun in the work groups. Take care.
Thank you.
Hello?
Janelle, are you starting?
Okay. Is the go-ahead, you can go ahead now? We'll start.
Yes, you can.
Perfect. Thank you, Linda. So I'm not, well, as I do this presentation, I'm not able to see the participants. So I will rely on speaking up so that I know what the conversation is going on while I'm to talk. Thank you for joining us today during the Health Equity Work Group breakout session. I would love for us to take a few moments to just step back and do a quick introduction of those attending. I'm Janelle Plazas. I am Salish Kootenai. I am a First Nations Native American woman, and I grew up on the Flathead Reservation in Montana. I grew up in my culture and with my community, and as I grew up at a young age, a lot of my friends and family members began having children very young, and it was somewhat the attitude that an expectation that I would follow the suit, and those were my life opportunities. And it was only after leaving the reservation on a school program that was funded by an Office of Minority Health that I got to see what it was like off the reservation. And I took it to Seattle through the University of Washington during this program and exposed to health. And that stayed with me and sustained me through my education. And I became a nurse and a nurse midwife, and I got a PhD. And my early work centered upon Native American women's health, looking at their families. And I wrote a few papers that, based on my dissertation, that looked at teen parenting among Native American communities, and a follow-up postdoc study that looked at fatherhood of Native American women. I believe that the work I did, where I looked at the ramifications of historical trauma and ongoing marginalization of, in particular, Native American communities and Native American women, piqued the interest of someone who then tapped the shoulders of the people who thought that I would be a part of SACIM. And I am very privileged and very proud to be able to be on this board. Currently, I am a nurse midwife working at a Kaiser hospital in California. I do have children. I have been doing basically homeschooling since March for children and working nights and try to include the work that needs to be done for SACIM and health equity in particular. It is a passion of mine to help give voice and help understanding of situated context and lived experiences and the health effects of individuals and communities. So I will end with that. And Belinda, would you like to go next?
Sure. I am Belinda Pettiford. I am in North Carolina. I work for the State Division of Public Health and have been working in the field of public health for 33 plus years and have worked in the area of either women's health or health promotion or perinatal health my entire career. I have much of my focus has been on working in the area of maternal and child health with a specific focus on addressing disparities, improving health equity, including institutional and structural racism. It is, it's an interesting time in our country. It feels a little different this time around our response to obvious racism in our country. And so hopefully we will not lose that focus, but we do, I truly hope that it ends up moves into actionable items and not just be another conversation that we have and plan and still don't move things into implementation. I am one of 8 children, my parents, and I'm from a blended family. I don't have children myself, but at any point in time I can have them because I have over 30 nieces and nephews. So I am always concerned about them and how they are growing up in this country, and have really good conversations with them, especially the teenagers and the ones in their early 20s. So I'm happy to also be on this committee and joining in with Janelle to support the work. So Paul, would you like to go next?
Sure, I'm Paul Jarrett. I'm a family physician, practiced in many different environments, including rural health centers, federally qualified health centers, including homeless shelters for adolescents and inner city school, but also was with Kaiser Permanente as CEO of one of the Permanente medical groups for a while. I was Commissioner of Health in Vermont, had responsibility for mental health, substance use, and public health. Then came down and was the executive director of the Association of State and Territorial Health Officials for 10 years. And there, along with the presidents over time, was able to really establish a very important strategic direction around health equity and racism, institutional and otherwise historic. From ASCO, I went to the March of Dimes, where I was the Chief Medical Officer, and continued the work on birth equity there, including adoption of policies by our board on both social determinants and health equity, and launched a big multi-organ program for birth equity. I've been at MITRE Corporation now, M-I-T-R-E. We're a not-for-profit. Work exclusively with government and support of government. I'm the chief medical advisor there for our health work. So we have the Federal Research and Development Center for the Department of Health and Human Services at, HHS, the federal level, and advise across a number of areas, including some research and development in the area of maternal morbidity and mortality, and recently been working pretty much full-time on COVID-19 response with state and local, territorial, and tribal jurisdictions. So happy to join the group.
Welcome. And Ed, would you like to share anything?
Sure. I'm Ed Ellinger. I'm the acting chair of SACIM. When my mom grew up right on a farm just next to the Menominee Indian Reservation, which is now the poorest county in Wisconsin. And her brother married an American Indian, and he had lots of kids, and so I have lots of Native American cousins. But my mother was always incensed at the disparities that existed on one side of the line between the reservation and their farm and the communities around that. And so she instilled in all of the kids the fact that this was unjust, this was unfair, and it affected us directly because our cousins were impacted by the disparities that were so prevalent and the racism that was so prevalent in Wisconsin at the time. And so it sensitized me to the book that I read in high school, The Other America, by Michael Harrington, that highlighted the fact that we have at least two Americas, those that have a whole lot and those who have very little, those who have lots of privilege and those who are discriminated against. And it really enhanced me and encouraged me to go into healthcare, into medicine, and work on trying to do that. So all of the places that I've been working at.
And now I can't get the thing to expand. It always happens when I need to. Is it like, it's supposed to give you...
Oh. Could someone put us on mute, please? Thank you.
And so that has influenced my work. Where parents make a huge difference in what you do. So I ended up going to medical school, and I ran the maternal and child health program for the city of Minneapolis and did the first disparities report on infant mortality in the early 80s. Ended up also running a student health service at the University of Minnesota, and then was health commissioner in Minnesota for 7 years. I'm now retired, or more or less, but doing a lot of consulting and working on boards and committees, and enjoy this work chairing SACIM, because I think equity is an existential challenge for us in this country. You're seeing it right now. The the disturbances, the rioting, the protests that are going on are really saying that our society, the way it's set up, is just not equitable and cannot persist this way for very long. So I think it's an existential issue for us, and that's why it's been the focus of all of the work that I've been doing over the last 40 years. So I'm glad you guys are all partners in that.
Thank you, Ed. Thank you.
Janelle, we have other people on. I keep seeing in the chat box, Garrett Lorman, who's a court reporter. He says he does not have any volume.
Okay.
So I don't know, Chelsea, if you can help him with that.
Yeah, I'm going to retype in. Sorry, this is Vanessa. I asked the operator, and he said everyone should be in the main room now with us that's in this breakout on the line. So I'll just resend the passcode.
Oh, he says he has it now. He says
okay.
we have volume now, so he should be good.
Oh, okay. Thank you.
Thank you, Vanessa, for doing that. And then let me, so I opened up a new screen so that I could see maybe, but does it look like it's just the four of us, myself, Ed, Belinda, Paul, and Garrett? Are there other people also?
There are some others. It looks like you've got Ashley Belton and Garrett Lorman, and I'm getting ready to mess up Avrina Cropper.
Paul Wise is on as well.
It's such a small group, and I believe that Morgan shared that we can have everyone moved in to the same room we are so they can speak. I think we just have to let the operator know. How do we do that?
And is it possible that we can see each other if we don't need the slide? Because I'd really like to see everybody speak if possible.
Perfect.
I think someone was speaking.
Everyone's line.
Okay.
Oh, everyone's live? Thank you.
You're welcome. It'll just be one moment.
And
sorry, did you hear that Paul Wise is also on?
I'm sorry, what was that?
Paul Wise is also on the call.
Oh, Paul. Okay, perfect.
Thank you.
Welcome, Paul.
Thanks, Ed.
Yeah, and Janelle, I'm going to cut off in a little bit because I want to go to each of the sessions. So when I leave, it's not because you're not doing what I want you to do. It's I need to touch base with the other work groups.
All lines are now open.
Okay. So all the lines are open, and we are the only ones, it seems, because of the, if you're joining us now to the health equity, you are welcome to share your video camera if you'd like and join us by phone to speak up in the work group.
Hi, I introduced myself a little bit earlier, but this is Joya Chowdhury. I'm representing Rear Admiral Felicia Collins from the HHS Office of Minority Health.
Oh, perfect. Thank you. Okay, now I can see. All right. All right. Let's see. Ashley Belton, would you like to quickly introduce yourself?
I know Ashley. She's a project officer within the Division of Healthy Start and Perinatal Services within the Maternal Child Health Bureau. She's actually one of our project officers for our perinatal mental health grant. So if she can't hear, I'm sure that's the same Ashley.
Okay. Thank you. And then Averina Cropper, would you like to introduce yourself?
Sure. So my name is Averina Cropper. Can you hear me?
Yes.
Okay, great. I work for CMS Centers for Medicare and Medicaid Services in our Office of Minority Health, where I lead a couple of our maternal health projects. One in particular is our RFI that we submitted for comment. We actually just closed seeking comment on access, outcomes, and quality in maternal care for women in rural communities. And also we recently convened a rural health forum where we brought quite a few experts in the field to discuss barriers, challenges, and potential opportunities. So thank you for allowing me to be on this work group or just participate and observe. Appreciate it.
Yeah, thank you. Please. Would love your expertise and insight. And then Garrett, I believe that you are here to help us with taking all the notes, correct?
Oh yeah, I just unmuted myself. I don't know if you can hear me, but yeah, I'm muted here. I'm just transcribing what's being said.
Thank you. All right, and then myself, I'm here twice. And Joy introduced herself. Paul Jarris introduced himself, and then Vanessa. I believe you're also here to help with transcription. Correct?
Hi, Janelle. I'm Vanessa. Yes, I work at HRSA MCHB in the Division of Healthy Start and Perinatal Services, and I will be helping by taking notes to pass on today. The transcriber will have these notes for your official meeting minutes that will come out after the meeting. So I'm just going to take some highlights so that you have them for your work out.
Thank you.
Vanessa also has quite a long history at HRSA and a lot of expertise, so I hope you feel free to speak up, Vanessa, also.
Yeah, please do.
Thank you.
Please do.
And it looks, Ashley put in the chat box that she apparently is still muted. Operator, is it supposed to be *1 or? I'm trying to help Ashley get unmuted.
Understood. It looks like all of the lines in the conference are currently unmuted.
Okay. All right. We'll keep reading her thoughts in the chat box. Thank you.
You're welcome.
Okay, thank you. All right, so after the, thank you for doing all the introductions, and now let's get down to business. I want us to kind of imagine what the future will look like 500 years from now, 200 years from now, 100 years from now, and working backwards, what are the things that need to happen to get us there? And we're definitely going to address immediate issues related to COVID and the current racism going on in our nation, especially with COVID. But I want us to just kind of also think in the big picture of what it looks like, what does a healthy nation look like in the future, and how do we get there? Consistently, we're one of the worst rated countries in terms of maternal child health, even though we're a developed country. And what are the steps that we need to take? And from presentations this morning, especially with Joya's presentation, addressing human rights as a fundamental framework for helping move forward with recommendations or moving forward with action. I believe that's something that health equity, this work group, should incorporate fundamentally to help move us along. One of the questions I have in terms of what we can do right now, what are to make immediate changes, what can SACIM do to recommend taking actions over the next 6 to 12 months to improve maternal infant health? And we've discussed this a little bit in the past 2 hours or so. We've talked about Ed's letter as far as like a template of how we are going to, the general SACIM letter that will be given to the secretary. So we've talked about telehealth medicine. We've talked about access to out-of-hospital care and services.
we've talked about testing. So, well, maybe we've talked about testing a little bit, but I think that in previous conversations, our group has also talked about pandemic-wide response and how not just testing, but contact tracing needs to be instituted. And of course, the policies that follow in hospitals and organizations regarding standardization for testing. And just recently, I don't know who has read the news, but it was recently revealed that a New Mexico-based hospital in Albuquerque was found out to have been using racial profiling in their hospital by conducting tests, COVID testing on Native American-looking women. And it is widely known that the Dene, the Navajo Nation, has been more disproportionately impacted by COVID, the COVID pandemic. And so in this particular hospital, Native American-looking women were tested without their knowledge and then separated from their babies. So what do we do to rectify this? What are the policies that should be in place that would not allow something like this to happen? So I'm going to open it up for just general thoughts of what should SACIM do that would impact women and infants' health immediately, addressing the underlying racism and historical marginalization that continues to go on a number of vulnerable populations.
And Janelle, you're referring to things beyond telehealth and the things we talked about this morning, or are we repeating some of those?
We can move beyond that, I believe, because we've had a lot of discussion on that, but we can, what are some, if there are additional specific things that we should do, or there are some considerations that we need to consider that we've already discussed today, telehealth or access to delivery options or testing, but are there additional issues?
I think one of the areas that we have not talked about is that even though some people are aware of the historical trauma and just the historical issue of racism in our country for different populations, not everyone is aware. So I do think we've not really focused a lot on racial equity training or implicit bias training and how you connect it to overall efforts. I don't know how well it does if you just do the training and you don't do any follow-up or any other connections. But I just feel like we need to have some, we do need to include some information on the importance of training on historical racism in our country, how it has impacted populations, and how our own implicit biases that we all have impact how we treat people, how we respond to situations, how we develop programs, and how we, all of those moving parts. I think that's a piece we probably should be adding in.
I think there's also a real tendency to look at interpersonal racism as the problem among, these bad people, of which, of course, none of us are them, as opposed to really looking at it from the point of view of the historic, institutional, and systemic racism, which is, I think, yes, we have the evil of interpersonal racism, but the underlying institutional, historic, institutional, and systemic is so much more toxic. And somehow moving from this, few bad apples to the real underlying problem is something we've got to do. A disconnected thought, we tend to really take note in this country when there's a big event, whether that's a school shooting or, in this case, which is tragic, or the death of, the pattern. But each time another person of color is killed by police, we take note. We have to, but that's symptomatic of the underlying problems as well as a specific problem. And I guess what we don't do is, like after a school shooting, we get all outraged, but we don't consider the deaths that occur every day, particularly among certain populations. And so somehow also move, how do we create an environment or take advantage of the attention now to bring forth the daily disparities in health, the daily birth inequities. They're not as dramatic. You don't see it on the video camera, but they're far more deadly. And I'm not saying it's an either or, but somehow we have to move across. Because again, we can say, oh, those police killings are a few bad apples or a few bad departments or, whatever. But it's much more pervasive. We've got to get at it systematically. So it would be a shame if it would be wonderful, I guess, to say, is there an opportunity to get birth equity on the menu as